Okay. Good evening, everybody. Good evening, my colleagues. Today is the Wave 2 webinar of European Society of Hypertension with our distinguished speakers, Dr. Enrico and Dr. Costa. And also we have our distinguished national speakers. This in conjunction with the CVRAP and audiovisual by Icon Business. Today we have interesting lectures. The first lectures by Dr. Ahmed Shawi, and the second lecture by Enrico and Dr. Tarek Zawawi. Enrico and me is dealing with the moderation, and we'll have a fruitful discussion. I hope so. And I need from you to send the questions via chat or question answer, and I will collect the questions and trying to answer in the same session. Dr. Ahmed Shawi?
Yes, ready, sir. Okay, to start off with, I want to thank CVRAP for the lovely meeting. We are now in an era of webinars, but this is really one of my first conferences to attend, and it was lovely last week and hopefully this week. Very well done to CVRAP, very well done to ICOM, and hope for the successful meeting. Today, we're going to talk about management of hypertension after a stroke. And we know stroke, which is the third world killer in the developed countries, is a very important cause of death. And hypertension is probably the most important modifiable risk factor for this stroke. Not only hypertension in the systolic blood pressure, but also in the diastolic. Actually, any increase in systolic or diastolic increases the risk of stroke. And this is important to take into consideration. It's not just the systolic. Of course, there's more data on the systolic, but there are also data on the pulse pressure and other factors that we should take into consideration. So this is very important that when we talk about hypertension, it could be due to stroke, and a stroke can increase hypertension too. But before we talk about what happens after a stroke, we should try to prevent the first stroke. And we know lowering the blood pressure in all data, whether it's by any medication, there is reduction of stroke by nearly 35 to 40%. And there is a prevention concept all over the world right now to lower the blood pressure, to stick to lifestyle modifications, would be it the ESC, the HA, ACC, and ESH. This is really important. Before we get the problem, let's try and avoid the problem. And blood pressure management is important. We saw how lowering the blood pressure to below 120 in the SPRINT trial really reduces strokes, myocardial infarction, and cardiovascular death. And there is data also that this lowers dementia. But of course, in the very elderly, lowering the blood pressure excessively may increase a little bit of the problems, and this is not well established to lower the blood pressure below 120. What happens? Our brain has an autoregulatory system. When there is an increase in the cerebral perfusion pressure up to between 50 and 150, the autoregulation is really working there to ensure a consistent cerebral blood flow. Above that, we can have edema and increased intracranial tension. But this is in normal situations. In hypertension, this is shifted to the right with the autoregulation at higher levels. But when we have an ischemic event, like a stroke, the problem totally alters. There is a linear correlation between the cerebral perfusion pressure and the cerebral blood flow. Thus, any increase in pressure is required to assess, to have a good cerebral blood flow. And lowering blood pressure may actually sometimes injure in the acute event the brain tissue in an acute stroke. Not only that, also tissue oxygenation is important, and the amount of oxygen extraction fraction is changed in ischemia and with treatment. So again, maintaining a blood flow during an acute infarction of the brain is quite important to take into consideration. And there is always this question, do lower or not to lower in an acute event? There are arguments to lower. Of course, there is benefit seen in primary and secondary prevention trials. And we know if there is an increase in blood pressure, the rate of stroke might increase. Not only that, with an increase in blood pressure, you might have hemorrhagic transformation of the stroke. If you have a very elevated blood pressure, you cannot really manage these patients by thrombectomy or thrombolysis. But of course, against the active treatment, acute hypertension in most or a lot of stroke patients is usually transient. And reduction or very quick reduction of blood pressure in acute stroke maybe have a poor outcomes. And the cerebral autoregulation that we just discussed is totally not working in the proper way, and this might lead to problems in the brain. And of course, if you have a patient with a stenosed intra or extracranial arteries, lowering the blood pressure might lower the cerebral perfusion pressure and thus increase the stroke. So it's a little bit of a balance. When you have an acute occlusion, you have to support the penumbra, the area around the infarction. This increased blood pressure in the first 24 hours is extremely important and may be extended to 72 hours. Not so severe, and we'll talk about the numbers as we go on. And then we lower it gradually because, of course, increase in blood pressure increases morbidities and mortalities in acute stroke, acute hemorrhage, or even in just acute encephalopathy. And then there is the long-term therapy, and that's what we're going to discuss. And if we see data like in the acute Scandinavian candesartan acute stroke trial, lowering the blood pressure so much is really as bad as keeping it very high. Usually there is a sweet spot in the middle that we try to keep the patients in the acute stage, because lowering the blood pressure in acute stroke may be very deleterious to these patients. And there are so many studies discussing what to do, how to do it, what are the levels. But really, if you look at the data from admission trials, it's usually around 200 that we are going to intervene if it's above 200 or not. And if the patient's going to take fibrinolysis or have a thrombectomy, the data of most of the trials here, in fact, all of the trials show us it's 185 over 110. This is the cutoff point that we should lower to if we're going to have a thrombectomy or thrombolysis, and this is agreed upon in all data. So if we take a little bit of a crooked outline, we want the blood pressure to be below 200 and 100. And if there is going to be reperfusion, we try to lower it below 185 over 100. And after reperfusion, we try to keep it around 160 to 170. And of course, later on, the data that showed us, like SPRINT and other studies, going lower with 130, 80 or 130, 85. Of course, this was the usual data that. So which agents to use? This is important. In an acute stroke, when you have an increase in blood pressure, there are some medications. Of course, we don't have a lot of them, but of course, not written here, but nitroglycerin can be given. Labetalol, the alpha-beta blocker, is quite commonly used, and nicardipine intravenously is also very good because it causes cerebral vasodilation if there's a lot of spasm. But of course, if it's not controlled, you might use nitroprusside, but beware of nitroprusside because it increases intracranial pressure and relatively contraindicated, if not absolutely contraindicated, if you have hemorrhage. And then this is what you do later on, you lower the blood pressure accordingly. And what medications do we use after the acute event? This is what we're going to discuss in a few slides. The best data show us that all medications that lower blood pressure lower mortality from stroke and lower stroke rates. This is all blood pressure agents, but actually the ones that show benefit are the ACE inhibitors, the angiotensin receptor blockers, the diuretics, and the calcium antagonists. These are the ones with the best reduction on stroke rates overall. The beta blockers have a little bit of a problem. They showed a beneficial effect early on in the studies, but the meta-analysis show that the relative risk of stroke is not decreased that significantly by beta blockers. Going lower is important. This is just showing quickly that if we go lower with the blood pressure in the darker bar graphs or bar charts, we lower all strokes, if it is ischemic or hemorrhagic, and death also is decreased. And this is also another reason that lowering the blood pressure to 130 or lower is better than the previous data of 140. So this is really important to take into consideration. Lowering the systolic on the left and diastolic on the right lowers sometimes a lot of data that we should see. And this is, again, a look at the medications used, and so many data starting from guanifidine in the 70s up till now, and the data showing us the benefit of ARBs and the combination of also of perindopril and indapamide. Beta blockers, I again state, they are good in lowering blood pressure. They reduce myocardial infarction, but in stroke trials, a meta-analysis by the Cochrane review showed no benefit in reducing stroke rates from beta blockers. Maybe the newer ones will be better. Maybe the vasodilatory beta blockers will be better. But again, most of this data has been by atenolol. ACE inhibitors, really seen in the progress trial by perindopril and perindopril indapamide, the HOPE study. ARBs like valsartan, candesartan, telmisartan have all shown reduction of mortality and, of course, the calcium antagonists because of their vasodilatory effect. So here again, the best medications to be used in these patients. Then this is data showing from the progress that the combination of perindopril and indapamide reduces stroke significantly and lowers mortality too. So let's put this into a guideline. What do the guidelines say? If we look at the ACC-AHA guidelines, they say we should not lower a blood pressure, sorry, it's going a little bit quick, not lower a blood pressure which is below 185 over 110. We should lower it if it's higher, if we're going to have thrombolytic therapy or we're going to have thrombectomy. How much to lower it? In the first 24 hours, keep it around 180, 105. And then if the patient is not going to have any intervention, be it thrombectomy or thrombolysis, if the blood pressure is above 220 and 100 diastolic 120, then lowering it very quickly is not really important. Lowering it, if it's higher than that, by 15% in the first 24 hours, this is important. And this is a lovely chart showing you, if the patient goes to the left side that he's going to have thrombolysis therapy, go to a lower blood pressure of below 185, 110, keeping it around 180, 105 in the first 24 hours. If he's not, if the blood pressure is above 220, 110, yes, then you can lower the blood pressure by 15% in the first 24 hours. No indication to lower the blood pressure acutely in stroke patients unless you're going to have an IV thrombolysis or you have other indications like a cardiovascular emergency, like an aortic dissection, malignant hypertension, hypertensive encephalopathy. These are the indications for acute lowering of blood pressure. How about if you have an intracranial hemorrhage? Because I know this would have been a question. Again, there is lots of data, but lowering the blood pressure is indicated if it's the systolic is above 220. And there is a question between 150 and 220 because there are data with or data conflicting, and the most recent Interact 2 showed there's no really big benefit of lowering the blood pressure significantly during an acute infarction, acute hemorrhage, sorry. What if you have a transient ischemic attack? You can give the medications very quickly. And here, as we just said, the preferred medications are diuretics, RAS inhibitors, ACE or ARBs, and even in a caption, it's written there, a diuretic plus an ACE inhibitor as seen in progress. And we're looking at 130 or 80, and this is the goal for patients for the treatment for secondary stroke prevention. This is important to take. And for the first time, this is really nice to see that the American and European guidelines do not agree. They are just exactly the same numbers. And we know across the Atlantic, we have different numbers to stay. But here again, it's if you have an acute stroke, 220 or above, manage. If not, don't. And if you have a patient going for thrombolysis, you keep the blood pressure below 180 over 105 in the first 24 hours. If you look at it, exactly the same numbers. You can use medications if the patient has a TIA and you are looking for a target systolic blood pressure 120 to 130 and 80 millimeters of mercury in diastolic. And again, the best medications here are RAS blockers, a CCB, a thiazide diuretic. Again, both guidelines agree totally to this. My final thing is don't forget hypertensive emergencies, because we know that a stroke can have hypertension, but hypertension can induce also cerebral problems like an encephalopathy. And here we should really take care and lower the blood pressure accordingly to 20 to 25% of the mean arterial blood pressure. So my final slide, always try to avoid a stroke. control your patients and give them the best medications that reduce stroke. If you have an ischemic stroke and the patient is a candidate for thrombolysis or thrombectomy, lower the blood pressure below 185, 110, and keep it around 180, 105 for 24 hours. If the patient is not for a thrombolysis, then we're talking about lowering the blood pressure if it's above 220. And don't forget secondary prophylaxis. Our patients are going to have a big problem if we don't manage their blood pressure later on. We should follow up these patients regularly, all after their discharge or their well-being, because if we leave them without controlling their blood pressure, they're going to come again with an acute stroke. And thank you.
Thank you, Professor Ahmed, for this excellent presentation as usual. Thank you, Professor Ahmed Shawi, one of the eminent professors in Egypt and outside Egypt. Thank you very much. As you mentioned that during acute stroke, blood pressure reduction is hazardous. Type.
Yes.
Post-stroke, for secondary prevention, most of the guidelines recommend 130/80, as you mentioned, European and American. How many days post-stroke we are aiming to reduce blood pressure 130/80? This is number one. Number two, is it different between patients with already hypertensive before stroke or patients without hypertension before stroke?
Okay, thank you for the compliments. Thank you for the questions. First of all, it depends, firstly, how to control your blood pressure or the patient's blood pressure after a stroke. If the patient has a small TIA, we can give the medications in hospital and target the blood pressure that we're going for. There is a little bit of controversy here, or sometimes we see in the American guidelines, if the patient is not hypertensive, then we can go to below 140/90 or 130/80. This is a question to put in consideration how low. The age group here is also important. If you have a very elderly patient above 80, sometimes you would not like to reduce the blood pressure so much because, of course, their cerebral autoregulation is a little bit distorted. So a little bit of a systolic hypertension or elevated systolic blood pressure might be beneficial. But of course, we don't lower the blood pressure immediately if it's a very big stroke. We wait for 3 to 4 to 5 days in hospital. Then we lower it over a period of 2 weeks to 2 months, accordingly to the patient's symptoms and the patient's well-being.
Professor Eric, we have a comment about this?
Oh, I think it has been a very nice overview. The issue is perhaps what to do in patients with atrial fibrillation who have a stroke, how to manage the anticoagulant treatment. This may be an important point that will deserve some attention and discussion. What is your opinion?
That's a very good question. I know it was out of the context of the presentation, but again, this is atrial fibrillation, and reintroducing oral anticoagulants. It depends on the NIHS score of the patient. We can introduce the oral anticoagulants in a small TIA within 1 day, or if it's a large stroke with a high NIHS score, it can take 2 weeks. It depends, again, on several factors, and here the neurologist is an important cofactor in managing the patient and introducing the oral anticoagulants. But again, very nice question. Thank you so much.
Ahmed, regarding you have a question of the audience here. You have a patient with severe hypertension, either a patient is de novo or in aggravation of his hypertensive. What is because you have a table for hypertensive emergency? What is your pills given to the patient in the ER? Is it captopril? Is it calcium channel blocker? It is diuretics, because it's a big false. And because you mentioned here ARBs with diuretics, but for example others calcium blockers. So I don't know what's the exact answer of this. This is from the audience and myself as well for you.
Okay.
Enrico.
Okay, I'll talk about the ER because this is really important. Actually, we don't have data on most of the things we're using, like intravenous furosemide. This is not present. But there are data on a little bit of smaller studies on captopril sublingual in the acute setting of an ER. But again, here, this is rather hazardous, because if the patient is symptomatic and is going to the ER with an increased blood pressure, giving these medications at home in a pharmacy, they could be deleterious. The patient might have the blood pressure measured incorrectly. Most of hypertensive emergencies should be managed in an ICU or a CCU with, most of the times, intravenous medications if he's in acute hypertensive emergency, which is true. Professor Enrico, would you like to add to that, please?
Well, I think that in acute encephalopathy, for instance, in malignant hypertension, or let's say in acute increase of blood pressure and encephalopathy, the treatment is that you have suggested giving either labetalol or the calcium antagonist like erdipine, which is less used in our country, or clevidipine, and this should be initiated soon. If there is an acute increase of blood pressure without the signs and symptoms of encephalopathy, the reduction of blood pressure may be smooth. And I agree with what you said. Captopril not indicated in this case. It is a bit downgraded in comparison with previous experience. And the same drugs, as we said before, can be used at less dose, reducing blood pressure smoothly.
Okay. If a patient...
Sorry?
Sorry. Thank you very much, Ahmed Shawi, for this wonderful presentation as usual. And now I'm introduced my colleague. Ahmed Shawi, Professor Ahmed Shawi, for this wonderful talk as usual, which is very interesting, management of hypertension after stroke. Now, the second interesting topic, which is management of hypertension in coronary artery disease patient by my colleague and my friend, Professor Dr. Tariq Zawawi, Professor Cardiology and Geology, Alexandria University. Dr. Tariq.
Thank you, Professor Sobhi. It is my pleasure to introduce this presentation in the European Society of Hypertension highlights. Thank you very much. بدوس كليك ما بيتحركش السلايد. ما بيتحركش. بدأ ارجع بقى. Hypertension is an established risk factor for all clinical sequelae of coronary artery disease, and the commonest cause of death in patients with hypertension remains coronary artery disease, despite of the major advances in the therapeutic options for the treatment of coronary disease. Actually, the risk between systolic blood pressure and the risk of stroke and myocardial infarction is curvilinear, and the risk starts to increase rapidly after increasing the systolic blood pressure more than 1/4. Also, the cardiovascular mortality risk doubles with each 20 millimeter mercury rise in systolic and 10 millimeter mercury rise in diastolic blood pressure. And actually, in patients with blood pressure 175 systolic and 105 diastolic, 8-fold higher cardiovascular mortality risk than those with systolic blood pressure 105 and 115 and diastole 75. What is the impact of blood pressure reduction on the cardiovascular outcome in patients with hypertension and coronary disease? This is a large meta-analysis, including 1 million adults, shows that just 2 millimeter mercury decrease in systolic blood pressure results in 7% reduction in ischemic heart disease mortality and 10% risk reduction of stroke mortality. Also, there is a lot of results showing the beneficial effects of the treatment of hypertension as regards the risk of cardiovascular events versus those without treatment of hypertension in patients with coronary heart disease. And there is a large trial called the Europa trial. This trial included more than 13,000 patients with stable coronary heart disease, not hypertensive, and found that the use of ACE inhibitor, Brindbril, results in significant reduction of the cardiovascular deaths, non-fatal MI, and cardiac arrest. And based on this large trial, this is a breakthrough trial. Based on this trial, the European Society of Cardiology guidelines inhibitors class 2A recommendation in patients with hypertension, with coronary artery disease, without diabetes, and without left ventricular dysfunction. And this is another meta-analysis using the ACE inhibitors in patients with coronary artery disease and preserved left ventricular function, and showed that the use of ACE inhibitors increase all-cause mortality and the cardiovascular deaths. According to the European Study of Guidelines 2018, what is the threshold of blood pressure to start drug therapy? The threshold depends upon the age. If the patient is less than 80 years old, the threshold to start is 140/90. However, if the patient is 80 years or more, the threshold to start drug therapy is 160/90 or more. What is the appropriate blood pressure target in patients hypertensive with established coronary heart disease? Also, according to the European Society of Cardiology guidelines, recommend that patients below 65 years old, the target is 130 or lower, but not less than 180. If the patient is above 65, even above 80, the target is 150 to 135 systolic. And in all group of age, the target of the systolic is between 70 to 79 millimeter mercury. Can blood pressure be lowered too far in patients with hypertensive and coronary disease? Based on this study, showed that the risk of all-cause mortality increases with decrease the systolic blood pressure less than 40, and the mortality doubles if the blood pressure systolic less than 110. The shaped curve, this is old and new concept. According to the INVEST study, including more than 22,000 patients, showed that with decrease of the systolic blood pressure below 70, the risk of cardiovascular events is increased rapidly. However, the patients with revascularization, the risk was significantly lower than those without coronary revascularization. Which antihypertensive to use in patients with hypertension and coronary artery disease? The aim of treatment in those patients is the prevention of death, MI, stroke, reduction in the frequency and duration of myocardial ischemia, and improvement of the symptoms. According to the American College of Cardiology and American Association Guidelines 2014, ACE inhibitors, diuretics, beta blockers, all these drugs can be used in the spectrum of patients with hypertension and coronary disease, whether stable angina, acute coronary syndrome, heart failure. However, the calcium channel blockers can be used in stable angina and acute coronary syndrome and not used in patients with heart failure. Nitrates can be used in all groups of patients. Aldosterone receptor antagonist used in post-MI heart failure. And then the guidelines updated in the American 2017, and they mentioned that patients with ischemic heart disease, the goal, the same as the European, less than 130/80, and the best drug to use, the beta blocker, ACE inhibitors or ARBs, And if the patient does not reach the goal and still have angina, we can add dihydrogen calcium channel blockers. If there is no angina, also we can add dihydrogen calcium channel blockers, thiazides, or even mineralocorticoid receptor antagonists if indicated. This is class 1 recommendation. And according to the European Society of Cardiology 2018, the first line therapy is dual combination, and one of the gold standard in the dual combination is the beta blocker. We can use beta blocker with ACE or beta blocker with calcium channel blockers, beta blockers, even beta blockers with diuretic as a first line of therapy. If not controlled, we can combine 3 drugs. If resistant, we can add spironolactone or alpha blocker or other diuretics. If the beta blockers are contraindicated or produce intolerable side effects, we can use left ventricular function is normal. The Canadian guidelines 2020 recommend the initial treatment for patients with hypertension and stable coronary artery disease, ACE inhibitors and the beta blocker, or combination of these drugs with calcium channel blockers, second line therapy, and stress about avoid short-acting nifedipine. Short-acting nifedipine is contraindicated in patients with hypertension, even without coronary artery disease. There is no special contraindication to the other drugs that can be used in patients with stable coronary artery disease, as like nitrates, antiplatelets, anticoagulants, statin can be used. What should drugs to be used in patients with acute coronary syndrome? In acute coronary syndrome, beta blocker is the first line of the choice. However, if the patient is hemodynamically unstable, or the initiation of beta blocker may be delayed till stabilization of the patient, diuretics can be used also. Non-dihydrogen calcium channel blockers can be used if there is a contraindication for beta blocker, provided that the left ventricular function is normal. Also, longer acting dihydrogen calcium channel blockers can be used, thiazide diuretics can be used. If the patient is hemodynamically stable, ACE inhibitors can be added. If the patient has anterior MI, diabetes, hypertension is still not controlled, or there is evidence of left ventricular dysfunction or heart failure. Aldosterone receptor antagonist can be used post-STEMI with left ventricular dysfunction. This is class 1 recommendation. Also, there is no special precautions with the use of nitrates, anticoagulation, antiplatelets, statin for patients with hypertension and coronary disease, except the use of fibrinolytic therapy. The patient must be controlled because of risk of intracranial hemorrhage. And patients should be controlled without delay, early treatment of blood pressure control, because those patients are receiving antiplatelets or even anticoagulation. Also, the Canadian guidelines to 2020 for hypertension post-MI recommend also beta blocker, ACE inhibitors, second line therapy. We can add long-acting calcium channel blockers, and the non-dihydrogen calcium channel blockers contraindicated in patients with heart failure. Thank you.
Thank you, Professor Tariq, for this wonderful presentation. My question again, can you explain again regarding the diastolic blood pressure? Because still Enrico in the last week speak about the J curve and the problem of the J curve. So I need also Enrico to join us with this. Is you believe in J curve, so we believe in 70. If we don't believe in J curve, we don't believe in 70. So how can we solve this problem? Start by Tariq and then Enrico.
يعني still there is a lot of debate. إنما still as we know that the coronary blood flow depends on the diastolic blood pressure. Most of the trials found that in patients with coronary artery disease, the future of cardiovascular events increased if the diastolic blood pressure is low. especially the coronary blood flow depends upon the transmural myocardial pressure, the difference between the left ventricular and the diastolic pressure and the coronary pressure. But if the coronary pressure is low and the left ventricular and diastolic pressure is high, the coronary perfusion pressure is low, and the patient may deteriorate with myocardial ischemia. I believe that patients with coronary disease, we should not decrease the diastolic too much.
Enrico.
Yes, the pathophysiological explanation of the possible harm of reducing too much diastolic blood pressure is strong. Let's say that we have several demonstrations indicating that reducing diastolic blood pressure below 70 or systolic below 120 may be harmful. But all this demonstration, as I said last week, came from post-hoc analysis of clinical trials. There is no specific trial that prospectively look at this possible harmful effect. So the post-hoc analysis may be useful for generating hypotheses, and indeed we have several of these analyses all in the same line. For instance, the post-hoc analysis of the on-target study or of the value study all demonstrated that below certain value of systolic diastolic blood pressure, there is an increase of unwanted effect, a reduction of coronary flow in these patients. However, we need a prospective study so far, but we should be careful with these patients not to go too low at this moment. Another point that I would like to underline, according to European guidelines, is that in these patients, although we should not go below 120 systolic, 70 diastolic at present time, however, the goal blood pressure should be below 130 for systolic and 80 for diastolic. And this should be obtained even if patients are in the high normal range. This is perhaps one of the few cases in whom we have to start treatment, perhaps with only one drug or monotherapy in patients with high normal blood pressure, because we have some evidence that in this patient with coronary artery disease, to reduce systolic below 130 is good for them. Not below 120, but below 130, yes.
But my second question regarding the beta blocker and ACE inhibitor in hypertension with coronary artery disease. As you know, that hypertension without coronary beta blocker is not the first line, it's the fourth line. But an ACE inhibitor will be the first line, the combination with the diuretic calcium blocker. So why, as we know, the beta blocker has no influence on the prognosis of coronary artery disease patients. So if you have a patient with hypertension with coronary disease, why not to start with this ACE inhibitor rather than the beta blocker, and then if no response, can give a beta blocker, not the reverse? You understand my question? ACE inhibitor is and ARBs are the first line of treatment with a combination therapy. Beta blocker is the third or fourth in hypertensive patient without coronary. In coronary patient without hypertension, okay, beta blocker is given for the patient as the coronary patients, but not for hypertension. So it's no benefit of this. But ACE inhibitor has to be given. Is to as a patient with chronic stable angina, you can give 10 milligram perindopril or 10 milligram ramipril for patient with chronic unstable angina according to the HOPE and Europa study. So ACE inhibitors is beneficial in patients at the 10 milligram in that phase. So why not? Why not? I'm not speaking about trial. No, why not? To start with these kind of patient, ACE inhibitor or ARBs, and if there is no response, give beta blocker. but we have to have the answer for this.
Shortly, very shortly, I think the beta blocker are indicator if there is angina, an indicator if there has been a previous myocardial infarction. Otherwise, your suggestion may be correct.
Okay.
Just seconds. Beta blocker class 1 recommendation to improve the angina if the patient with a stable coronary disease has angina. Number 2, to control the heart rate, to improve angina, to control the heart rate, and if the myocardial ischemia 10% more is indicated. And for prognostic implication, we add ACE inhibitors or ERBs.
Okay, it will take a long time to discuss this, but we have to go to the. Thank you very much for this wonderful session, and we'll have Ahmed break. I think we can take 10 minutes break, and then we come to the next session. Thank you very much, Ahmed, Shawi, and Enrico. عمرو انت قدم هناء بقى.
Okay. We'll start.
Yeah.
Okay, it's my pleasure to be in this event. Of course, Dr. Sobhi is so active even while we are all enclosed indoors. And thanks to him and Sevirep and ICOM for this ninth gathering. It's my pleasure to introduce Dr. Hana Zawawi. It will going to talk about a really little bit tough subject in hypertension, which is primary hyperaldosteronism and Conn's syndrome. I wish you can explain to us a lot of mysteries in this familial hyperaldosteronism type 1, type 2, and type 3, type 4. I don't know, and the low renin and its resistant hypertension. So let's have you, Dr. Hana. It's our pleasure. We can hear you, Dr. Hana.
الو اي استاذ احمد، هو احنا بدأنا ولا لسه؟ انا مش سامعه حاجه. انا مش يعني خلاص ابدا.
We can hear you, Dr. Hana.
بسم الله الرحمن الرحيم. It's my pleasure to participate in European Society of Hypertension highlights. My topic today is primary hyperaldosteronism. The adrenal gland is formed of cortex and medulla. The medulla secretes catecholamine, and the cortex is formed of 3 zones. The innermost zone is the zona reticularis, which secretes adrenal androgen. The middle zone is the zona fasciculata, which secretes corticosteroids or cortisol. And the outermost zone is the zona glomerulosa, which secretes aldosterone. Extraadrenal sites for aldosterone secretion include myocardium, adipose tissue, and blood vessels. Angiotensin II is the principal regulator of aldosterone secretion, and to a lesser extent, serum potassium, vasopressin, and ACTH. Aldosterone's main physiological function is to maintain sodium and water homeostasis. Aldosterone plays an important role in the reabsorption of sodium and fluid in the distal renal tubular and collecting duct, and in potassium excretion as well. Primary aldosteronism, or Conn's syndrome, was named after Professor J.W. Conn, an American endocrinologist who first described the condition in 1955 in a patient with hypertension, hypokalemia, low plasma renin, and aldosterone-producing adrenal adenoma. Later on, scientists described the same condition, however, in absence of adrenal adenoma, for example, in the presence of hyperplasia. So primary aldosteronism is defined as inappropriately elevated aldosterone production in the setting of low plasma renin. Regarding the epidemiology, European or the Endocrine Society Clinical Practice Guidelines 2016 recognized primary aldosteronism as a major public health issue. Also, the 2017 American College of Cardiology defined the primary aldosteronism as one of the most frequent disorders, occurring in about 5 to 10% of patients with hypertension and 20% of patients with resistant hypertension, and the estimated prevalence is increased up to 30% when aldosterone ratio is produced, with a greater target organ damage than in patients with essential hypertension. Primary aldosteronism is about 2 times more common in women than men. Primary aldosteronism is the most common endocrinological cause of secondary hypertension and the most common cause of surgically curable hypertension. Adrenal adenoma is the most common cause of primary aldosteronism, accounting for about 50 to 60% of the cases, followed by adrenal hyperplasia. Aldosterone-secreting adrenal carcinoma is very rare, accounting for 1%, followed by familial hyperaldosteronism, which is 4 types. Type 1 familial hyperaldosteronism is called glucocorticoid-remediable aldosteronism, in which there is ectopic aldosterone activity in the cortisol-producing zona fasciculata of the adrenal cortex. So in this condition, the zona fasciculata of the adrenal cortex secretes both glucocorticoids and mineralocorticoids. Type 2 includes hyperplasia or adenoma of the adrenal gland in the zona glomerulosa. Type 3, there is genetic mutation in the zona glomerulosa, increasing aldosterone synthesis, and type 4 is associated with neurological and cognitive dysfunction. Regarding the pathophysiology, high aldosterone level potentiates renal sodium reabsorption, water retention, together with potassium excretion. This results in plasma volume expansion, which is the primary initiating mechanism for hypertension, which in turn induces tissue inflammation and increases the sympathetic drive with the subsequent development of fibrosis in vital organs such as kidney, heart, and vasculature, with consequently development of target organ damage as chronic kidney disease, atrial fibrillation, ischemic heart disease, or congestive heart failure. Clinically, the patient with primary aldosteronism complains of polydipsia, polyuria, muscle weakness due to hypokalemia, fatigue, and hypertension. Why primary aldosteronism is underdetected? In fact, traditionally, hypokalemia in hypertensive patients is the most common clue for primary hyperaldosteronism. However, normal serum potassium can be present in up to 40% of patients with primary aldosteronism. Thus, one of the most alarming or the traditionally known sign for primary aldosteronism can be lacking in about half of the patients. So, hypokalemia is by no means a necessary sign in searching for primary aldosteronism. And following this wrong strategy, many normokalemic patients with primary aldosteronism would never be screened or diagnosed. A second neglected reason why primary aldosteronism is underdetected is that primary aldosteronism is searched for only when plasma aldosterone concentration exceeds a given cutoff, usually 15 nanogram per deciliter. This will miss cases where the only clue to the disease is low plasma renin. These cases of normoaldosteronemic primary aldosteronism are usually misdiagnosed as low renin primary hypertension. Thus, aldosterone-renin ratio is the test of choice. According to the Endocrine Society guidelines, the workup for a patient with primary aldosteronism is a 3-step process, including first, case detection or screening, followed by case confirmation or diagnosis, then subtype classification. First, screening. The method of choice is the use of aldosterone ratio. But whom to be screened? Patients with sustained blood pressure more than 150/100, or those with blood pressure more than 140/90 resistant to 3 conventional antihypertensive drugs, or those controlled on 4 or more antihypertensives. Patients also with hypertension and hypokalemia, patients with hypertension and adrenal incidentaloma, patients with hypertension and sleep apnea, history of early onset hypertension or cerebrovascular stroke at young age, and all hypertensive first-degree relatives of patients with primary aldosteronism. Aldosterone ratio is a method of a choice for screening by the Endocrine Society Guidelines 2016 and also by the 2017 American College of Cardiology Guidelines. An aldosterone ratio more than 20 has a sensitivity of 78% and specificity of 83%. Aldosterone ratio should be interpreted in the context of plasma aldosterone concentration and the plasma renin activity. We should not rely on the ratio only, but we should also interpret in the presence of the plasma renin activity alone and the aldosterone alone, because sometimes inappropriately low renin or high aldosterone may lead to artificially elevated aldosterone ratio. For example, in patients with chronic kidney disease, the renin is low, so this may give a falsely elevated aldosterone renin ratio. So we should be cautious while interpreting the aldosterone ratio. Withdrawal of antihypertensive treatment is neither needed or necessary nor recommended before measuring the aldosterone ratio. However, the agents can be best chosen are the alpha blockers and the long-acting calcium channel blockers to avoid the effect of ACE inhibitors on aldosterone ratio. Unfortunately, a large fraction of patients with primary aldosteronism are underdiagnosed. So, case confirmation should be done in all patients with positive one or more of the confirmatory test should be done in patients with positive aldosterone ratio, patients with hypokalemia, plasma renin activity is low, high plasma aldosterone more than 20 in patients with hypertension. The confirmatory tests include oral sodium loading test, saline infusion test, fluorocortisone suppression test, and captopril challenge test according to the Endocrine Society. Failure of aldosterone to be decreased to a very low level or undetectable level after these provocative tests confirms the presence of primary aldosteronism. Then the three-step is followed by the subtype classification, which is the last step in the three-step approach. And we should do CT scan for all patients after the confirmatory test to exclude large masses which may represent adrenocortical carcinoma and to confirm presence of unilateral disease. This is an example of a normal CT scan of normal adrenal glands. Here the adrenal gland appears in inverted Y shape above the kidney, and we compare the thickness with the crust of the diaphragm. This is an example of a CT scan of right adrenal adenoma, and this is an example of a CT scan of the left adrenal adenoma, and here is an example of bilateral adrenal hyperplasia. Here the two adrenal glands are thickened in comparison to the crura of the diaphragm. Adrenal venous sampling is recommended by the Endocrine Society guidelines following the CT scan to distinguish between unilateral and bilateral adrenal disease, which is very important in directing the management of the case. In patients who are very young, when primary aldosteronism is confirmed, in patients below 20 years of age, genetic testing for glucocorticoid remediable aldosteronism or familial hyperaldosteronism type 1 is recommended, and in very young patients or children, screening for genetic testing for the primary hyperaldosteronism familial type 3. Regarding the treatment options, Endocrine Society guidelines recommend unilateral laparoscopic adrenalectomy for patients with documented unilateral disease. In patients with bilateral affection of the adrenal glands, medical treatment is recommended using mineralocorticoid receptor antagonists, spironolactone and eplerenone, and this is also the recommendation of the 2017 American College of Cardiology guidelines. Also, there is a more appealing attractive future therapy, which is aldosterone synthase inhibitor to abolish all aldosterone-mediated pathologies, which is future therapy. For patients with glucocorticoid remediable aldosteronism, the treatment option of choice here is using glucocorticoids. The patient should receive cortisol in order to lower ACTH from the pituitary as a negative feedback mechanism, and thus when the ACTH is decreased, there will be no stimulation for the zona fasciculata with subsequent decrease in aldosterone secretion, in this case, in the normalization of blood pressure. To summarize the workup or the approach for patients with primary aldosteronism, first we should do aldosterone renin ratio if the patient is clinically suspected to have primary aldosteronism. A ratio below 20, the patient primary aldosteronism is unlikely. However, ratio between 20 and 45, we should repeat and use confirmatory tests. A high ratio with more than 45, then we can do adrenal CT for lateralization and for exclusion of adrenocortical carcinoma, and then the use of adrenal venous sampling to distinguish between unilateral and bilateral disease and confirm the lateralization. In the presence of unilateral disease, surgical treatment is the treatment of choice, while in the presence of bilateral disease, medical treatment is the option of a choice. So my take-home message: primary aldosteronism is a common curable form of hypertension characterized by high plasma aldosterone and low plasma renin. Patients with primary aldosteronism have higher cardiovascular morbidity and mortality than patients with essential hypertension within similar blood pressure levels. Early identification, therefore, and the treatment of primary aldosteronism is essential and cost-effective. However, diagnosis of primary aldosteronism still remains challenging. Case detection should be performed by using aldosterone ratio, followed by case confirmation and the use of CT. In unilateral disease, standard of care is surgical adrenalectomy guided by adrenal venous sampling. In bilateral disease, medical treatment is the gold standard using mineralocorticoid receptor antagonist or future therapy with aldosterone synthase inhibitors. Thank you.
Thank you, Dr. Hannah.
سامعة حضرتك.
Excellent presentation, Dr. Hannah, and you covered all subject. Then for surgical treatment, you should be sure that the adenoma is secreting.
Yes, we should be sure that it is secreting, and it should be unilateral. No surgical treatment for bilateral disease. It should be unilateral.
Yeah, and even in the unilateral, you should sample both venous sites with the inferior vena cava, because sometimes the other are excreting more, even in the presence of adenoma.
Yes. Yes.
Okay.
Yeah. How easy? Congratulations for this nice, excellent presentation. Practically speaking, are there any centers in Egypt that could perform adrenal vein sampling in this case of primary aldo? Because as far as I know, very few centers in Europe could perform successfully, I mean, with experience, venous sampling in order to determine if there is really primary aldo. What is the situation in Egypt? What is your practice?
Actually, the guidelines do recommend, the guidelines, Endocrine Society Clinical Practice Guidelines do recommend adrenal venous sampling. However, if the patient is young age, documented on CT scan presence of adrenal adenoma with all the hormonal profile, sometimes we cannot use the adrenal venous sampling in this case. In very young patient where there is documented presence of adrenal adenoma on CT scan, presence of hypokalemia, presence of the full-blown picture, and all the criteria, we should not, we cannot revert to the adrenal venous sampling. However, the guidelines do recommend.
I know that the guidelines recommend, but even in the most experienced labs, only 60% of these cases, in the end, they succeed to receive this, let's say, sample. So, practically speaking, I think, as you very nice describe, is the clinical suspicious and to detect potentially case, and then starting with the aldosterone-renin ratio, taking into considerations all these drugs that may affect the determination of this ratio. Your practice, if you have cases that with a suspicion of primary aldo, you stop the antihypertensive medication replacing with CCBs or alpha blockers, or you perform the aldosterone-renin ratio while the patient receives the regular therapy?
Actually, the guidelines is not clear about that, but in clinical practice, it's better to stop the ACE inhibitors or ARBs for 2 weeks before doing the aldosterone ratio, and we can replace them using calcium channel blockers or alpha blockers clinically. And
also, it's very important to the patient not to restrict the salt consumption during the determination of aldosterone-renin ratio.
Yes. Sure.
Thank you.
Thank you.
Can I ask you another question, Dr. Hannah? Because we have suppressible renin and unsuppressible renin. Is there any difference, and salt restriction is better for one than another?
Salt restriction is not recommended before measuring aldosterone ratio. Just the antihypertensive, we can best choose the antihypertensive like alpha blocker, calcium channel blocker, and avoid the ACE inhibitors. But we have a confirmatory test, the aldosterone ratio test. We should interpret it first. It is a screening test, and we should interpret it in the context of plasma renin activity alone and the plasma aldosterone level alone. This is number one. We should consider if the patient is salt sensitive. We should consider if the patient has chronic kidney disease. All these should be considered. Then number three, we should use confirmatory or provocative tests like the saline infusion test and these tests. Failure of the aldosterone to be decreased after all these documents or proves the presence of primary aldosteronism.
Quite a question from the audience, Hannah. Thank you very much for this wonderful lecture. If it is bilateral, why surgical therapy is not helpful?
Because here we will remove both adrenal glands should be removed, and the patient will be lifelong on replacement therapy, hormonal, full hormones of the adrenal glands. And this will be not feasible. So it's better to use the mineralocorticoid receptor blockers.
Okay, my question to you: I read the Jack article, and I astonished that it is primary aldosteronism will come back, because already when I was young, I remember a few cases to be diagnosed resistant hypertension. So I discussed with the patient, then responding to the high dose of aldosterone antagonist, then stopped, and then we don't have, as Costa said, we don't have this adrenal sampling. We don't have it in Egypt. Costa, the answer to the question, we don't have this. We have only the AR, because already depending on the clinical and the AR ratio and the CT. And otherwise, there's no other sampling done in Egypt, because I noticed some cases and discussed with the radiologist and even urologist, they don't have this sampling. So my question from the audience for you, why it is there's some difficulty in AR ratio itself, false positive, false negative. And even in hypokalemia, you said that's 40% normal. So 40%
yes.
spectrum. So why you are diagnosing this case of primary aldosteronism?
Yes, this was based on multiple randomized controlled trials that not most of the patients discovered with the primary aldosteronism have hypokalemia. Also, patients use the aldosterone ratio is just a screening. It's not a confirmatory test. It's just a screening test, and should be interpreted in the context of the renin alone and the aldosterone alone, then followed by the confirmatory test. So maybe hyperaldosteronism is increased nowadays, maybe due to the use of screening programs and the use of diagnostic tests. Maybe in the past it was not discovered because it was many of the cases are missed. Many of the professors or the clinicians rely on the presence of hypokalemia to diagnose primary aldosteronism. Also, there is a very important thing, which is normal aldosteronemic primary aldosteronism. Sometimes the aldosterone should not very high. Only the low renin level is the diagnostic in this case. So this may be why it was in the past underdiagnosed, and now more screening programs are implicated. And aldosterone ratio is just a screening. Confirmatory test should follow.
Thank you very much.
Thank you.
Another comment, Dr. Sobhi, rapid comment.
Yeah.
For the unilateral, it's better to be removed, because even if you continue on medical treatment and you have both controlled blood pressure, you have increased risk of more morbidity and stroke in those with the tumor inside. So it's better to be removed.
Okay, thank you. Okay, thank you very much, Hannah. Now Costa is our distinguished. Okay, put your slide, please. Thank you, Costa, again for sharing with us in the European Society of Hypertension, the CVRAP. Costa is going to give an important topic, which is very, very common, I think, management of hypertension and chronic kidney disease. This is a popular topic for the cardiologists, internists, and those nephrologists as well. Sometimes it's so difficult. So because of the types of drugs used and the mechanism. So I need to learn a lot from Costa, and we have a fruitful discussion at the end. Costa?
Thank you, Mohammed. Nice to be with you all again. And this talk is related in a way to the previous excellent presentation by Hannah. There is no doubtful about the close relationship between hypertension and kidney. We know that kidney disease are very common cause of secondary hypertension. And on the other hand, we know that impaired pressure natriuresis curve is fundamental for the pathogenesis of essential hypertension. Also, kidney is a target of hypertension, as Mohammed previously said, and also kidney should be considered as a base of hypertension therapies. Diuretics, RAS blockers have their main place of action on kidney, and recently renal denervation also targets the renal sympathetic efferent and afferent fibers. So today, I will discuss very briefly the epidemiology and the prognostic role of chronic kidney disease, how to assess kidney function in the setting of hypertension, what are the blood pressure targets, and how to achieve the blood pressure targets in a patient with impaired kidney function. Data from USA clearly show the size of the problem. CKD exceeds 13% of the population. And we know very well that patients with chronic kidney disease are more likely to die than develop end-stage renal disease. Sudden death and myocardial infarction account for 62 and 20% of cardiovascular mortality, respectively. The cardiovascular mortality of end-stage renal disease is 30 times higher compared to general population. For this reason, the current guidelines, American and European, addresses chronic kidney disease as a coronary artery disease risk equivalent in the risk management of hypertensive patients. This is the fundamental study by Go, published 20 years almost ago, clearly show the close association between deterioration of kidney function and all-cause death and cardiovascular event. Particularly when the GFR goes below 30, we see a dramatic increase in the deaths from all cause as well as in the cardiovascular deaths. So, non-doubtful about the detrimental effects of deteriorated kidney function. And what are the causes for end-stage renal disease? The last decades, diabetes mellitus and hypertension represent the most common causes for end-stage renal disease. What is the prognostic role of chronic kidney disease in hypertensive patients? We have data from many clinical trials, and in these slides I present some data from the ALL-HAT study, this fundamental study, where a baseline GFR of about 50 was independently associated with 32 higher risk for coronary artery disease. And patients with a moderate to severe reduction in GFR has 6 years rates higher for coronary heart disease than for end-stage renal disease. That means, in other words, that the risk of patients with impaired kidney function is to develop cardiovascular disease before the development of end-stage renal disease. This is also very nicely presented in these slides. The close association between heart and kidney disease. Heart and kidney disease have the same starting point in the asymptomatic stage. The classical risk factors, hypertension, diabetes, obesity, age, smoking, affects both the heart and the kidney. And before the development of the heart failure or of chronic kidney disease, both pathways are characterized by the preclinical organ damage. At the level of heart, we have left ventricular hypertrophy, we have left atrial dilation, we have diastolic dysfunction, reduced CFR. At the level of the kidney, we have a slight decrease in GFR and the development of microalbuminuria. And apart from the close association in this end stage, in other words, this is the cardiorenal syndrome, also we have identified in a publication a couple of years ago that also we have the preclinical cardiorenal syndrome. And in this line, we appreciate here a close association between the severity of left ventricular hypertrophy and renal outcome. Left ventricular hypertrophy is an independent risk factor not only for cardiovascular event strokes, but also for chronic kidney disease. And the combination of the left ventricular hypertrophy with CKD is associated with 3.2-fold risk for stroke, coronary artery disease, and death, compared to those hypertensive patients without left ventricular hypertrophy or without chronic kidney disease. Those who have either left ventricular hypertrophy or chronic kidney disease are having an intermediate risk. Not only GFR and serum creatinine is related with adverse prognosis, but also we have recent data showing that renal resistive index that could be very easily estimated by ultrasound, it is also increased in patients with resistant hypertension. And also we have evidence that routine kidney ultrasound could in the early stage of the diagnosis of hypertension may contribute to the better assessment of cardiovascular risk in hypertensive patients. What the guidelines recommend? Measurement of serum creatinine and GFR, as well as measurement of urinary albumin-creatinine ratio is recommended to all hypertensive patients as a routine test, class 1. And just to remind you that we estimate the GFR by using the well-established equation. Just keep in mind that the use of MDRD equation is better in the elderly, in overweight, or individuals with increased plasma volume, as patients with resistant hypertension or those with low GFR. The Cockcroft-Gold formula should be used with attention in those in healthy people, while the CKAP equation is better for those with GFR over 60. Microalbuminuria, just a few words, are very common among hypertensives, with a prevalence incidence range from 10 to 40%, depending on the aging, depending on the duration of hypertension, and also depending on the method that we have selected to measure the ratio albumin to creatinine. And we have plenty of data supporting that microalbuminuria is an independent risk factor for cardiovascular disease. We see here microalbumin, the relative risk is increased for in presence of microalbuminuria, for hospitalization, for congestive heart failure, for all-cause death, and for major cardiovascular event. Assessment of microalbuminuria is recommended according to the Diabetic Association, American Diabetic Association guidelines for all hypertensive patients, for all diabetic patients, but also for all hypertensive patients is a recommendation for starting from 2007 in the European hypertension guidelines. Also, the European guidelines, as well as the American ones, in the estimation of the cardiovascular risk, based on the score system, the European ones, clearly report that patients with severe CKD, GFR less than 30, are classified in the category of very high cardiovascular risk. Moderate GFR, CKD, GFR 30 to 60, less than 60, 59, classify the patients in the category of high risk. So no question about the adverse prognostic role of CKD in hypertensive patients. And if we see this nice table in European Society of Hypertension, we like so much this stratification of cardiovascular risk based not only in the blood pressure levels, but take into consideration the presence of other risk factors and the presence of target organ damage. And we appreciate here that patients with CKD in grade 3 are classified in the category of high and very high risk in relation to the blood pressure levels. What should be the blood pressure targets in patients with chronic kidney disease? This is a long history with different targets in different guidelines. Just to recall in your memory the results of the SPRINT study, which provide interesting results for patients with and without chronic kidney disease at baseline. In patients with chronic kidney disease at baseline, there is no difference in the primary CKD outcome between comparing the intensive versus the standard blood pressure targets. No difference in the rate of dialysis, kidney transplantation, or reduction of more than 50% in GFR. But having a look in patients without chronic kidney dysfunction at baseline, interestingly, intensive therapy was associated with worst outcome in the incidence of albuminuria and the reduction more than 30% in GFR. So intensive blood pressure reduction is not good for patients for protecting renal function, at least according to the SPRINT study. What the guidelines recommend? The American guidelines recommend to start a therapy. The threshold for starting therapy for chronic kidney disease is over 130/80, and the target should be less than 130/80, the same target for all the subgroups. But the European guidelines, the European Society of Hypertension, European Society of Cardiology guidelines 2018, as you know, we provide this target blood pressure range. Personally, I think this is a practical and realistic and good recommendation, and very simple. And for all hypertensive patients, we recommend below 140, below 90. But if tolerate for those less than 65 years old, for uncomplicated hypertension, we recommend to target 130, avoiding to go below 120. This is true for hypertension and diabetes, for hypertension and coronary artery disease, for hypertension, the risk of a stroke. But for patients with chronic kidney disease, we recommend a little bit higher target. To target 140 or to 130, avoiding to go below 130. The same target for those who are elderly. So for patients with chronic kidney disease, independently of the age, the European guidelines recommend to below 140 to 130. And for systolic, for diastolic blood pressure, the same target for all categories of hypertensive patients, including patients with CKD below 80 to 7. In patients, and this is also clearly report here, that in patients with chronic kidney disease, diabetic chronic kidney disease, non-diabetic chronic kidney disease, it is recommended that an office blood pressure over 140 be treated with lifestyle advice and blood pressure lowering medication, class 1 level of evidence A, and also it is recommended to, in all patients, diabetic and non-diabetic and nephropathy, to lower systolic blood pressure to a range of 130 to 139. Of course, individualized therapy should be considered according to tolerability and impact on renal function and electrolytes. And RAS blockers are more effective in reducing albuminuria than any other antihypertension drugs, and they RAS blockers are recommended as part of the treatment strategy in hypertensive patients in the presence of microalbuminuria. I would like to take this opportunity to mention that even in the era of COVID-19, the European societies, European Society of Hypertension, but also the European Cardiology Society clearly released a statement that there is no any reason to discontinue RAS blockers because of concerns of COVID-19 infection, just since we discussed about RAS blockers. A combination of RAS blockers with CCBs or diuretic is recommended as initial therapy, as the concept of the current guidelines is in favor of single pill combination for most patients on the initial visit. And this is the algorithm: initial therapy, dual combination, RAS blocker with RBS, with CCBs, or RAS blocker with diuretic. Of course, if the GFR is less than 30, we have to use loop diuretics instead of thiazide or thiazide-like diuretic. And as a third step, we will prescribe a triple combination. For next since chronic kidney disease is very common among patients with resistant hypertension, we have to add spironolactone, but of course take into consideration the side effects and the limitation associated with spironolactone and the plernon administration in patients with chronic kidney disease, special attention to the serum potassium levels. So, in this summary, in this slide, I present in summary these recommendations, whether the patient has microalbuminuria or non-microalbuminuria. There are some debates and some challenges in treating such patients. Goal, in our case, below 140, below 90. Treat microalbuminuria with normal blood pressure. There is no clear indications what to do in these patients. Treat microalbuminuria if hypertension. Yes, as the guidelines recommend. What should be the goal of blood pressure if we have albuminuria? It seems that also we have the same targets below 140, but avoid to go below 130. All the guidelines recommend RAS blockers for the therapy of patients with chronic kidney disease. But additionally, one more useful information, it's about our ability to regress the renal damage. The regression of invert GFR is very low, but what is fast is the regression of microalbuminuria to normal albuminuria. However, we don't have clear data whether the regression of microalbuminuria to normal albuminuria is associated with improvement in cardiovascular outcome. While this is not the case for left ventricular hypertrophy, we have in this case more solid data showing that the regression of left ventricular hypertrophy will result in the reduction of cardiovascular events. And if someone is interested in regarding the management of hypertensive patients on dialysis, this consensus paper is very interesting and strongly recommended. And also the same interesting topic is about the management of hypertension in patients with renal transplantation. It's also a useful paper released by European Society of Hypertension. And this is my last slide. Prevention is better than cure. This famous statement of the father of ancient medicine, Hippocrates, is true, particularly true in patients with chronic kidney disease. Everything in excess is opposed to nature. This is also a statement of Hippocrates is related to the blood pressure targets in the field of chronic kidney disease, and attention should be paid to preserve renal function, perhaps with the same vigor as we attempt to salvage and protect the cardiac muscle. Thank you so much for your attention, and don't forget to treat the patient, not only blood pressure numbers. And I would like once more time to remind you that the European Society of Hypertension meeting in 2022 will take place in Athens, and I will be more than happy to see many of you to attend and to participate in this meeting. again, many thanks for the invitation and for this participation in this very nice virtual meeting. Thank you.
Thank you, Costa. Thank you, Costa.
Thank you. Thank you very much, Dr. Costa. It's very illustrative lecture. But I'd like to ask maybe a silly question, but why CKD is a very high risk in the category? It's classified as a very high risk in patients with cardiovascular disease. This is due to the under treatment, because most of the patients are not having their coronary angio, for example, and the PCIs and bypass grafting as the normal, or because comorbidities as anemia, or because of most of them have electrolyte imbalance. So what are they playing most in this?
Very nice question, Amri. There is no one answer. Of course, what all these are potential causes is multifactorial. The cause for being CKD as an equivalent to coronary artery disease and patients at high risk. I think that patients with chronic kidney disease are associated with many comorbidities. When the patient has impaired kidney function, that means they are diabetics, and uncontrolled diabetes mellitus for a long period of time, uncontrolled hypertension, obesity patients, underlying atherosclerotic disease underdiagnosed for the reason that you mentioned previously. We have the fear to deteriorate kidney function by performing CT or by performing a coronary angiography. You know, when we have a patient with a GFR, let's say about 30, no one wants very easily to go this patient to the cath lab. On the other hand, this is the patient that would benefit most by, let's say, going to cath lab. I think the guidelines highlighted the importance of high risk of patients with chronic kidney disease in order to attract more attention to this group, because really they die from cardiovascular disease before their kidney function deteriorates so much and go to dialysis.
Yeah, sure.
Costa, there's a question regarding the drugs. Now, first question regarding the SARBs. I know that tomorrow there's a debate for diabetic nephropathy between SARBs pro and con, but I mean the dose, because most of nephrologists doesn't like to give SARBs in moderate CKD or EGFR or low GFR. And is there any role of renal antagonist in such kind of hypertensive patients?
If you have a hypertensive patient with impaired kidney function, first of all, no difference between ACE inhibitor and RBS. I know that there are some studies, particularly with supraphysiological doses of RBS, 900 milligram of irbesartan. I remember some studies showing more regression in the proteinuria to microalbuminuria and to normal albuminuria. But the general thinking is that these drugs are beneficial. But of course, on the other hand, we have to close monitor the patient. If we see that serum creatinine is increased by 50%, we have to discontinue this. Also to check the serum potassium level, not to go below over 5 or 5.3. And in this case, we have also to take into consideration the extent of plasma volume, to be the patient very well hydrated in order to avoid further deterioration of the kidney function. But the general belief is that to try to have all these patients in the maximum tolerated dose of RAS blockers, take into consideration the GFR and the serum potassium levels.
Okay. And about renin-angiotensin, renin antagonist, the renin antagonist, not only the.
Sorry, the renin antagonist. I know that I know the studies that seems that direct renin antagonist who had also a favorable effect on the kidney function. But unfortunately, nowadays the company Novartis is not so much interested in this drug after the results that they have in the combination with valsartan. And so I think that there is no now place to have this drug. At least in Europe, I don't know in Egypt, but in Europe, we don't have the direct renin aldosterone, the direct renin inhibitor.
In the sub-study of using Entresto, these effects.
Entresto, yeah. Okay, I know. Entresto is sacubitril valsartan, neprilysin inhibitor. It seems that also would be, and also this.
It sounds not clear.
Yeah. So, okay.
عمرو انت هتبقى معايا.
واتساب حاضر.
Thank you very much for this wonderful two talks with Dr. Hana, Dr. Costa, and thanks Amr. And we have a break for 2 minutes, and then we have an important Novart session with Professor Sada. Thank you. Yes. Okay. It's a great pleasure for me to introduce my colleague Professor Muhammad Sada, Professor Cardiology, Alexandria University, about the essential intervention, and I have with me the moderator Professor Tariq Zawawi and Professor Amr Zaki. Dr. Sada.
Good morning, good evening, everybody. كل سنة وانتم طيبين جميعا، يعني مسلمين ومسيحيين، وأيام جميلة لينا كلنا، وإن شاء الله يعني نعدي الأزمة دي كلنا على خير. الحقيقة أنا first of all I would like to thank Novartis for يعني kind invitation to present Novartis Symposium. This is during important webinar of European and Egyptian Society of Hypertension gathering. I will talk about the essential intervention regarding the Entresto. I would like to start with this kind of patient is Mr. K. He's 68 years old, known to be ischemic patient, had 2 attacks of acute coronary syndrome. He put 2 stents in the right coronary and LED 5 years ago. He's hypertensive patient. He's diagnosed as heart failure with reduced ejection fraction with 20% 3 years ago by his physician. Since then, he's been hospitalized once for acute heart failure. Since then, he's taking all anti-failure measures as per European Society of Cardiology guidelines, AC inhibitor, beta blockers, mineralocorticoid receptor antagonist, and diuretics. During follow-up, by his signs and symptoms become more and more worsened. He have constant fatigue, presented with shortness of breath, which occurs with ordinary physical activity. He cannot conduct a normal ordinary life. As you can see here, due to progressive nature of heart failure, patient cannot be precised as stable. So you cannot tell a patient with heart failure, this is a stable heart failure patient. Because with every frequency of decompensation, the risk of mortality with acute event and sudden death occur with progressive time course. As you can see here, in the beginning of the diagnosis, patients start to limit his daily physical activity, then become decompensated, not able to conduct a normal ordinary life, then become bedridden till mortality. So we are treating this patient to improving the quality of life. This is very important. We are not treating numbers, we are treating patient. So we have to concentrate about the quality of life, which is concerning about the patient himself. 76% of the patients struggle to perform their daily activity. 63% of the patient reported symptoms that are consistent with depression. We are treating patient also to prevent hospitalization. We all know that hospitalization is a great burden for healthcare professionals and for the patient and for the family and for the healthcare community. In developed country, heart failure is the primary cause of hospitalization in patient aged more than 65 years old. We have repeated admission, discharge, readmission, and 44% of the patient will be hospitalized at least once per year. When we look at the reducing mortality also, this is another target to treat this kind of patient. We all know that AC inhibitor, ARBs, beta blocker, and mineralocorticoid receptor antagonist are all main player in treatment of heart failure, but on maximum estimation, the maximum is beta blocker reducing mortality by 34%. Approximately 50% of those patients will die within 5 years of the diagnosis. In this period, these patients are very, very fragile patients, and they are more risky patients because COVID-19 poses high mortality risk in elderly and in elderly and cardiovascular disease. When we look at this graph, we look at this overall risk. If it is high mortality, then followed by cardiovascular disease, diabetes, chronic disease, and hypertension. As you can see here, mortality rate jumped to 6% in hypertension. Mortality rate jumped to 6% in hypertension, 7.3% in diabetes, 10.5% in cardiovascular disease patient, and 14% more than 80 years old. So notably, the case of mortality rate for underlying cardiovascular disease is 10%, is greater than patient with underlying chronic respiratory disease, 6.3%. So it's double the risk in comparison to respiratory disease. It is COVID-19 airborne transmission. No reported airborne spread for COVID-19 till this moment, but mostly transmitted by skin, hair, clothing, and beds, and unprotected contact. Also, aerosol producing procedure can generate this type of infection by ventilating patient, endotracheal intubation, tracheostomy, chest physiotherapy, and sputum induction and bronchoscopy. All these procedures can prone patient to had COVID-19 or the healthcare professional by themselves. Actually, unplanned hospitalization in the ER department and emergency department visit for stable chronic heart failure patient pose high risk for acute infection. That's why most of us are trying to keep our patient away from hospital during this high risk period because of the high risk to get COVID-19. As you can see here, heart failure patients are more likely to visit the ER more than any other type of chronic cardiac illness, which can significantly increase the risk for nosocomial infection. That's why this kind of patients are very risky to get the COVID-19. When we look at the British Society for Healthcare for Heart Failure, they have a very important statement here. The British Society of Heart Failure would like to request that symptomatic heart failure patients be recognized by the government as extremely vulnerable group who should be shielded alongside those people most risk of severe illness requiring hospitalization if they catch coronavirus as set out in NH letter. So trying to keep this high risk group of patients out of the hospital as much as you can by phone contact, by out of the patient clinic, trying to get them out from the hospital because they have the high risk to get the COVID-19. Evaluation of symptomatic heart failure patient as high risk for COVID-19. Patients with heart failure are often frail and have multiple health conditions, which put them in the high risk category on exposure to coronavirus. And therefore, vital, wherever possible, that we manage their patient outside the hospital setting. With this new priority of treatment goals, when we look at the hospitalization benefit gained from the analysis of the paradigm heart failure, interest to significantly reduce the risk of the first heart failure hospitalization, keeping failure patient out of the hospital. We have 40% fewer hospitalization evident within the 30 days of randomization, 23% fewer admission for heart failure, 18% fewer stay of intensive care, 29% fewer patient hospitalized more than once for heart failure, and 30% of fewer emergency department visit for heart failure. And we look at the global data in comparison to the enalapril, we have 21% relative risk reduction of the first hospitalization during the long period of follow-up, which is around 3.5 years. When we look at the pioneer heart failure, time to first heart failure readmission, also the hospitalization benefit here is so clear. The initiation of in-hospital Entresto is more effective than enalapril at reducing heart failure readmission after hospitalization for acute decompensated heart failure. So if you have a patient with acute decompensated heart failure, and this patient, the enalapril and those arm on the sacubitril valsartan, the readmission again is very high with the enalapril group. We have 45% relative risk reduction for the recurrence of hospitalization. Also in Pioneer heart failure extension, we will look at the serious clinical composite endpoint in the open label phase up to 12 weeks. We look at that shifting patient from enalapril into Entresto in the midway of treatment, completely different if you are starting Entresto from first day of discharge from hospital. So the early prescription of Entresto for those kind of high group of patients in the hospital keep them away from hospitalization again, rather than shifting them from conventional ACE into Entresto. And also we have 33% relative risk reduction. A strategy of in-hospital versus delayed initiation of Entresto is safe and well tolerated and led to early improvement in both discharge outcome that was sustained over 12 weeks. We have 33% reduction in serious clinical composite endpoint versus enalapril. That is, the message here is so clear that to keep your patient in the hospital prescription of Entresto before discharge, not to titrate ACE first, then to shift into Entresto. When we look at this quality of life, which is also a very important goal to treat this kind of patient, when we look at the different parameter of the quality of life, like dressing, climbing stairs, doing some backyard jobs, household chores, we have further improvement in the group of the Entresto rather than conventional ACE in all kind of parameters. Significantly reduce the risk of heart failure hospitalization, keep heart failure patient out of the hospital. So this is our aim here in the cardiology community right now, to keep up with heart failure as much as out of hospital. If we can rewind the time, 3 years ago, that was the best we can do for de novo heart failure patient, like our patient, Mr. K. If you have this past medical history of repeated MI and PCI with history of hypertension, he has a constant fatigue, shortness of breath, and he cannot perform daily activity. His X-ray showing cardiomegaly and poor ejection fraction. So we have newly diagnosed heart failure patient. Better for him to prescribe Entresto at the first of all, rather than ACE inhibitor. Let's have a look at the evidence. Since 2017, Entresto has 3 new trials, including ACE in naive de novo heart failure patient. It means that this kind of patient not receiving ACE or ARB before prescription of the Entresto, this is naive patient, have Entresto from the beginning of their diagnosis of heart failure. We have the transition heart failure, which represent 24% naive patient. Pioneer heart failure, we have almost half of the patient are naive, not receiving ACE or ARB before, and in the Pioneer, which around 14% not receiving ACE or ARB. When you look at the transition in hospital initiation of sacubitril valsartan in stabilized patient with heart failure and reduced ejection fraction. When you look at this data, we have that initiation of Entresto is well tolerated in ACE or ARB patient. Most of us are afraid to prescribe this kind of drug in the hospital. We would like to give them ACE or ARB first to up-titrate the dose, then we reinitiate the Entresto. But this trial is answering the question that 24% of those patients are naive, receiving Entresto from the beginning. And what are the data? The data showing that in patients with heart failure who are naive, sacubitril valsartan can safely be initiated, up-titrated, and maintained with similar safety and tolerability of patient who was previously treated with ACE or ARB. So both arms are completely safe. So it doesn't matter those patients received ACE or ARB before, then you can shift to Entresto, or you can start Entresto from the beginning as regarding in terms of safety. A rapid and significantly greater reduction in biomarker of myocardial stress injury upon treatment with ARNI in ACE or ARB naive compared to not receiving those, like the propionP or high sensitivity troponin, showing further improvement on those kind of patients. Also, initiation of sacubitril valsartan in patients with de novo heart failure, when you look at the analysis of this study, Entresto should be considered as a first-line therapy in de novo patient hemodynamically stabilized after acute decompensated heart failure. When we look at the side effect, there is no statistical significant difference between those receiving ACE then shifted to Entresto rather than those receiving Entresto from day one. Also, we have the pioneer heart failure. The pioneer heart failure is the angiotensin receptor neprilysin inhibition in acute decompensated heart failure based on the prior exposure to conventional renin-angiotensin system antagonist. When you look at this trial, if you have no ACE or ARB before, I mean naive patient, or if you have an ACE or ARB before, the further reduction of the pro-PMP here is much more than on those ARB. That the benefit here is much more than the benefit here. Also, when we look at the Kaplan-Meier estimating the cumulative of cardiovascular deaths or rehospitalization for heart failure, if you look at the data here, if the patient is naive, he gets more benefit rather than those receiving ACE or ARB. So we are wasting time here as you look at the data, this time of randomization. We are wasting up to 1 month before the difference become in this curve. But here, the benefit started from early days of initiation of the drug. So Entresto titrated to the target dose based on systolic blood pressure should be considered as the first line of therapy in patients with acute heart failure independent of the previous RAS exposure. But here I have to stress on one point that in this trial, we started the Entresto whenever this patient is completely stable out of the intensive care without vasopressor drug for 24 hours, his blood pressure is stable, so you can start the drug completely safe. When we look at the important trial, also the PROVE trial, the prospective study of biomarker, symptoms improvement, and ventricular remodeling during Entresto therapy for heart failure, the PROVE heart failure study. When we look at this study, there's a rapid and significant reduction of NT-proBNP was observed with a majority of reduction in the first weeks from being up 12 months in all significant parameters. When we look at the subgroup of interest, those who are naive, not receiving ACE or ARB, we have, which represent 15% of those patients, we have further improvement ejection fraction in diastolic volume, in systolic volume, and all remodeling process. To conclude, in this important paper from the European Heart Journal of Heart Failure, the Clinical Practice Update in Heart Failure 2019, Pharmacotherapy and Devices in Management of this Expert Consensus document. What recommendation here we can see? Initiation of Entresto rather than ACE or ARB may be considered for patient hospitalized with new onset heart failure or decompensated heart failure to reduce short-term risk of adverse event and to simplify management by avoiding the need of titrate ACE first, then to switch into Entresto. Because these patients are already high risk of event, there is no need to check plasma concentration of atrial natriuretic peptide to initiate Entresto because they already have acute heart failure in the intensive care. In this ambulatory setting, the guidance remains mostly unchanged. However, the paper stated that Entresto is safe and effective in broad spectrum of patients with heart failure with reduced ejection fraction. Its safety similar to ACE or ARB naive patient, and thus its initiation may be considered also in these patients. And I think in the future guidelines of heart failure, this will be changed, not to test the ACE or ARB first, then to switch. It will be like the American guideline to start from the beginning, the Entresto. Our conclusion slide, patients with heart failure are often frail, have multiple health conditions, which put them in high risk group in exposure to coronavirus. Therefore, whenever possible, that we manage this patient outside the hospital. Try to keep this kind of patient out of the hospital. Entresto significantly reduce the risk of heart failure first hospitalization by 21%. Entresto significantly improve nearly all quality of life, physical and social activity compared to enalapril. Initiation of Entresto rather than ACE or ARB may be considered for patients hospitalized with new onset heart failure or decompensated heart failure to reduce short-term risk of adverse event and to simplify management by avoiding need to switch or to up titrate. Entresto is safe and effective in a broad spectrum patient with heart failure, and it's safely similar to ACE or ARB naive patient, and thus its initiation may be considered also in ambulatory setting. And finally, I would like to thank you all for your good listening. And finally, I would like to state that Entresto is an essential intervention in those patients. Thank you.
Thank you, Sada, for this illustrative part of Entresto. So you have 4 trials for the Entresto. I mean, you have a patient with chronic heart failure. Do you hear me?
Yes.
Okay. And patient with acute heart failure. Shield the screen gun. Remove the. Okay. Tursada, so you have transition heart failure, pioneer heart failure, proof heart failure, and pioneer extension, paradigm heart failure. So we have 4 trials. You mean that chronic failure already on the guidelines, but now we're shifting to de novo heart failure with acute onset. At the end, you said that it is to be the changing the guideline to be European change to be like the American. Do you think that because we have this webinar or with this conference on hypertension, and we have a registry by Dr. Hassanin about the etiology of heart failure patients in Egypt. Most of the patients had hypertension, then ischemia, and 30% are diabetic, or 35%. Do you think that if you have a hypertensive heart failure, this drug, the drug of choice of heart failure patient?
Of course, because yes, if you have a hypertensive patient with heart failure, the conventional treatment was valsartan 80 milligram twice daily, 160 milligram twice daily. Why not if you add something with valsartan like the salcupatril? It's an added tool to the valsartan in those kind of patients. So you are, as we said in Arabic, يعني اضرب عصفورين بحجر واحد. انت you are treating hypertension with the valsartan with maximum dose, and you are treating heart failure with valsartan plus added benefit of salcupatril with all proven outcome regarding reducing mortality, hospitalization, quality of life. So we are treating multiple targets with drug.
Okay. Tari, you have any question?
يعني السؤال بتاع حضرتك هايبرتنسيف with heart failure، احنا زي ما قلنا ان الهارت فيلير هل هو ريديوس ايجكشن فراكشن ولا بريزيرفد ايجكشن فراكشن؟ فلو هارت هايبرتنشن with reduced ejection fraction I think ده very excellent جروب اوف ذا دراجز اللي انا اديه ومش هخاف من هايبوتنشن والكلام ده. انما لو هارت فيلير with preserved ejection fraction هنا بقى في يعني تحفظ شويه. ادي
هلعب على حاجه ثانيه. انا ممكن في ده زي ما انت بتقول هو عنده افكتيف في الومن والدايابيتك، خلاص انا هلعب في الومن والدايابيتك وبريزيرفد في باراجون هارت فيلير. ما الباراجون هو لما عمل الميد رينج وعمل سب ستادي لقى الومن والدايابيتك، خلاص هشتغل عليهم. لو عندي ومن ودايابيتك وبريزيرفد، انت مش تقول سب ستادي باراجون هشتغل عليه. يبقى انا قصدي ان احنا بنتكلم على هايبرتنشن دلوقتي، يعني هارت فيلير ويز هايبرتنشن، وكان في كلام عليه. فده ينفع وده ينفع في البريزيرفد في الاثنين دول، وفي كل ريديوست هارت فيلير. وهو دي يعني متهيألي كده حسب كلام صدى يعني، ولا انت شايف حاجه؟
هنا هيبقى انكارجنج ان انا ارفع الدوز
صح كده،
انكارجنج تو انكريز ذا دوز تو 200 مللي جرام توايس ديلي
بروفايدد ان الرينال فانكشن في العيانين دول نورمال. بروفايدد ان الرينال فانكشن في العيانين دول نورمال. اي ثينك ان ممكن في العيانين دول نوصل ل 200 مللي جرام فيري سيف.
يس.
طب انت قلت حاجه ثانيه يا صدى على الاكيوت هارت فيلير، لو انت بتديه لازم العيان يبقى اوف انيتروبس مش كده، ودي هايدريتد
24 ساعه
24 ساعه صح. بس في حاجه في الستاديز بتقول لك في 24 وفي اب تو 2 ويكس، يعني هم في اللي هم البايونير وفي الترانزيشن، في فرق بين الاثنين، في واحده على طول وفي واحده بعد ما يطلع من المستشفى.
اللي بعد يطلع من المستشفى الترانزيشن، البايونير جوه المستشفى،
وما لقوش فرق بين الاثنين.
والاحسن طبعا لان المجموعه دي من العيانين فيري هاي ريسك. اي ثينك ان العيان ده حتى لو مش اول 24 ساعه بعد الانتروب، لو استنى 48 ساعه والعيان ده وقعد في اوضه عاديه، اتس فيري جود اوبورتيونيتي انك تدي الدواء والتايتريت الدوز وتتاكد انه مش هيحصل فيرست دوز هايبوتنشن، وتتاكد ان الالكترولايتس والرينال فانكشن بتاعت العيان ستيبل. وفي الحاله دي العيان ويل ادوبت الدواء فور ايفر، لان هو لسه مجرب دي كومبنسيشن ولسه مجرب دخول عنايه مركزه، ودي طريقه اعتقد انها تكونفنس العيان ان هو تستريكت للدواء فور ايفر. يعني
دكتور محمد،
اي دكتور عمرو اتفضل.
معلش انا فور ايفر دي هقول لك بس let me speak to you frankly because usually I used to give the interest to from the start 2 years ago or 1.5 years ago, because I'm totally convinced that if it is playing after ACE, it will play from the start. But to tell you the truth, the sustainability of the patients and the adherence to the drug when you prescribed in hospital, I'm not speaking with evidence, it's a clinical practice. It's less than shifting, because our patients usually stick from the hospital, take the drug, then afterwards he's seeming better, and for financial reason he's getting his drug by his own. He used to shift with me. So the adherence here is not totally, I'm not totally agreeing with you, because the patient usually in the first 3 months after hospitalization is okay, but later on, why not taking another drug? I didn't have the other one. I tell you the truth, because this has happened several times. So it's not true.
الكلام حضرتك بتقوله ده I think ان هو completely right في ال early days of prescription of the drug 2 years ago or 3 years ago, but right now اعتقد بعد الدخول يعني whenever the drug in the health insurance system which cover more than I think يعني 55% of the population in Egypt.
No, it's complicated.
لا.
Right now it's very simple. Right now it's very simple. The patient go to the consultant of cardiology.
Ejection fraction should be 30, should be like that.
35 or less. 35 or less
yes, we are prescribing
acceptable renal function and electrolytes. And after that, we give them the prescription for 6 months. They don't need to go to the hospital except every 6 months to renew the prescription. Otherwise, he go to the consultant every month, follow up his condition.
But so remember right now, okay. Remember that acute heart failure, they should, not all the patient with 30%, okay? Acute heart failure, you have a patient with acute heart failure and ejection fraction 40.
لا ما هو بيتكلم على reduced. ده reduced يا عمرو على حسب الكلاسيفيكيشن reduced. العيانين دول ما كانوش
and the ejection fraction
ما كانوش mid range
يعني. And let me tell you, Dr. Amr, right now.
So this is connection.
طيب انا هجاوب يا عمرو اولا ان هم في 2 points يذكر you are completely right ان انت difficult if financially difficult، لكن انا بقول لك دلوقتي يمكن لجنه التامين احنا لسه كنا عاملين ويبينار 2 days ago مع نوفارس وكل الدلتا الكسندريا ودلتا، واحنا الكوميتي بتاعه الهيلث انشورنس احنا واخدين البروتوكول اتعمل يونيفايد، ويمكن هنبتدي تشينج within months بعد الكوفيد ان شاء الله. هو حاطينه على 35 الحقيقه، على 35% اللي هو الاجكشن فراكشن، وانما more than 35 yes you are right ان هو لا، لكن لو هو 35 واقل وما نوت ريسبوندينج وجايب بريسكريبشن وجود ايكو ينفع بيكمل. وبعدين every 3 months البيشنت دول بيجوا لنا انا موجود في اللجنه وانا اللي بمضي انا مع صدقه او بتوع التامين، وفي الدلتا نفس الكلام نفس الكلام. وعندنا a lot of patients، عندنا hundreds of patients دلوقتي الحقيقه هم ان بيمشوا، بس لازم نزود بقى فيها ان احنا هاو تو انكريز ذا دوز، دي مش موجوده كانت في البروتوكول انك توصل ل 200 لكن اتليست العيان بيكمل 50 مرتين في اليوم. دي نمبر 1. النمبر 2 اللي انت بتقوله صح، ان انت مش شرط ان العيان لو انت شايف العيان مش بس انا شايف ان العيان مش لازم من ساعه المستشفى، ممكن يطلع وهو بره هنقول له هنكمل لك دي، يعني ديبيندز دي بيرسوناليزد ميديسن بقى، يعني مش شرط.
بس انا عايز اضيف دكتور عمرو ودكتور محمد ان في البروتوكول احنا كنا الاول العيان اللي بيبقى حصل امبروفمنت، يعني في مجموعه من المرضى العيان بيبقى الايجكشن فراكشن ب 30% وبعدين بياخد الدواء ويكمل فور ريزون اور انذر، وفي الفولو اب يبقى الايجكشن فراكشن مثلا 40-45، فالعيان بيبقى خايف ان احنا ما نديلوش الدواء بقى، يقول لك انا حصل امبروفمنت في الايجكشن فراكشن. فالحقيقه احنا قلنا برضو في البروتوكول ان حتى لو حصل له امبروفمنت في الايجكشن فراكشن مش مجموعه كبيره، احنا عارفين نسبه قليله، لكن بيكمل برضو على الدواء ومن حقه انه يكمل وياخد الدواء على حسب البروتوكول مع التامين الصحي.
صدق في سؤال لك هنا موجود جالي من
اتفضل.
Patient with left ventricular dysfunction and no heart failure can be treated with Entresto، يعني قصدهم
يعني
او يعني عندك ليفت فنتريكولار ديسفانكشن، اصل الديسفانكشن دي بقى مش بوست مايكارديال
اسيمتوماتيك.
مع السؤال كده ما عنديش ان اسيمتوماتيك.
يبقى كده اسيمتوماتيك ليفت فنتريكولار ديسفانكشن.
هو ده السؤال اللي هو هايبرتنسيف يا دكتور صبحي. هو ده السؤال اللي احنا جاوبناه يعني.
احنا جاوبناه الويمن اند دايابيتيك سب ستادي، لكن مفيش اي بروف لغايه دلوقتي ان هو يتاخد از فيرست لاين تريتمنت يعني.
Okay.
Thank you very much, Dr. Sada. Thank you, Amr and Tariq.
Thank you.
We have a break 10 minutes and then we have a last session.
Okay. Thank you. Thank you. Thank you very much.
Okay. Good evening, everybody. I think this is the last session today with an important debate. I have with me Professor Enrico Rossi, the past president of the European Society of Hypertension. Thanks, Enrico, that you have with us for the third day, and you made a great effort doing many lectures and sharing in debates with this important relationship between European Society of Hypertension and CVREP Foundation, together with Costa. And I have also with me Professor Amin Fouad, Professor of Cardiology Military Academy. He's interested in hypertension. He was a reviewer of the Egyptian site in European Society of European Society of Cardiology regarding the guidelines of hypertension. And also Professor Tariq Zawawi, who made a lot for this program. Thank you, Professor Tariq, for doing everything. And then we have today an important debate between Dr. Said Farag and Dr. Enrico. Dr. Amin, you can introduce the first speaker.
Okay, thank you, Dr. Sobhi, for bringing the European Society of Cardiology here in Egypt. And now we have the highlights from the European Society of Hypertension. Now we have a very hot topic that has been a point of debates between the American and the European guidelines, the diabetic nephropathy, which is better, the ACE or ARB. So we have two eminent speakers with us, Dr. Said Farag, as you introduced him, the professor of cardiology from the Gazik Hospital, who is speaking about ACE is better in diabetic nephropathy. And then we will have a lecture from the Professor Dr. Enrico, who will speak about the ARBs as better option in diabetic nephropathy. So we will start with Dr. Said Farag. Please, Dr. Said.
Bismillah ar-Rahman ar-Rahim, Mr. Chairman, dear professors and colleagues. First of all, I'd like to thank Professor Sobhi and all the CVREP board for keeping life on, for keeping the scientific life on in the era of COVID-19. Also by sharing with the eminent Italian professor these ESH highlights. Actually, my part of the debate about an important topic, which is the diabetic nephropathy. It is an old but gold story with an extreme cardiovascular and end-stage renal disease risk. Diabetes, the most common cause, as you see from 2000 United States renal data system, that the most common cause of end-stage renal disease is diabetes. And if we can appreciate here that the diabetes is presenting 50% of those patients who will undergo dialysis in the US renal data system. Another important issue here is diabetic with macroalbuminuria are more likely to die than to develop end-stage renal disease. And this statement came from an important study, which is the United Kingdom prospective diabetes study, that those patients newly diagnosed, predominantly white, medically treated with no albuminuria, they have a 1.4% risk of cardiovascular death. And if they develop microalbuminuria, which they are transmitted by 2%, the risk is doubled to be 3% risk for cardiovascular death. And from microalbuminuria, if they are developed macroalbuminuria, which representing 2.8%, the risk again increased to be 4.6% cardiovascular death. And if the macroalbuminuria is transformed to a frank renal impairment, and this represented 2.3%, it is a huge jump in the risk of cardiovascular death to be 19%. We can appreciate here the risk of diabetic nephropathy for those patients with macroalbuminuria a long time ago, almost 17 years, for developing cardiovascular death. Another important article here about the contribution of diabetes to chronic kidney disease burden in the US, and this came from an important survey done in Hans from 2019 to 2014, over about 16,000 patients estimated for the diabetes mellitus status, the albumin creatinine ratio, and the eGFR. And we can appreciate here that the difference between diabetics and non-diabetics as regard the chronic kidney disease status. For those diabetics, any chronic kidney disease representing about 25%, while in non-diabetics representing only 5.3%. Also, the albumin excretion ratio, the creatinine ratio above 30 milligram is 16% in diabetics versus 3% in non-diabetics. Again, the albumin creatinine ratio more than 300 is 4.6% versus 0.3% in non-diabetics, and the renal impairment with eGFR less than 60 is 12% in diabetics versus 2.5 in non-diabetics, and the severe renal impairment 2.4 in diabetics and 0.4 in non-diabetics. And they came to the conclusion, after all these different significant differences in percentages between diabetics and non-diabetics, that diabetes is strongly associated with albuminuria and reduced eGFR, independent of demographics and hypertension, and of course contribute substantially to the burden of CKD in US patients. If you have a look here to this graph, which demonstrate to us causes of chronic kidney disease in people with and without diabetes, and we can appreciate here that the mechanisms behind the people with diabetes is already multi-directional. It might be due to diabetic nephropathy per se, it might be hypertensive nephrosclerosis, and it might be also ischemic nephropathy. So we have more than one bad guy sharing and contributing in the development of diabetic nephropathy in those patients with diabetes versus people without diabetes mellitus. This is also an important graph which shows us the stage of nephropathy, and we can appreciate here that we have to estimate it by the urine dipstick or the 24-hour proteinuria or the albumin creatinine ratio. But there is an important point here that we have not to miss by the using only the urine dipstick that those patients having microalbuminuria, because by collecting 24-hour urine, 30 milligram per day protein to 300 milligram per day protein, it's considered as negative by dipstick. And that's why we cannot depend only on dipstick for diagnosing microalbuminuria, or we will miss those patients, and of course we will not direct them to the proper strategy as regard the management of their diabetic nephropathy. We also have those with over nephropathy and above 300 milligram per day protein, or they have albumin creatinine ratio above 20 milligram per millimole. Up to 1000 milligram per day proteinuria, up to albumin creatinine ratio 67 milligram per millimole. We have also here to consider during tailoring the management of those patients with diabetic nephropathy, the stage of the chronic kidney disease of all types. We have to consider though that stage 1 as GFR more than 90, stage 2 from 60 to 90, stage 3A from 45 to 60, there is 3P from 30 to 45, stage 4 from 15 to 30, and of course the end stage renal disease, which is stage 5, the GFR is below 15. That's why the evidence, more than one evidence came to the stage, especially those from the European Society of Cardiology recommendation for prevention and management of CKD in diabetic patients, and it gives it the most high recommendation, which is class 1 level of evidence based upon a lot of evidences and researches. A RAS blocker, ACE or ARB, is recommended for the treatment of hypertension and diabetes, particularly in presence of proteinuria or even microalbuminuria. Not only from the European Society of Cardiology, but also a few months ago from the American Diabetes Association, they gave the light to those patients that they have initially give them an option, include ACE inhibitor or angiotensin receptor blocker as a line of prevention and treatment. Again, here in the American Diabetes Association, which stated a very important statement that in non-pregnant patient with diabetes and hypertension, either an ACE inhibitor or an ARB is recommended for those with modestly elevated urine albumin creatinine ratio from 30 to 300. And of course, it is strongly recommended for those patients with higher and gross proteinuria or urine albumin to creatinine ratio more than 300 milligram per kg. So both European and American are recommending RAS blockers for those patients with diabetic nephropathy. Here is again from the American Diabetes Association a very important recommendation, which is class 1 recommendation, that an ACE inhibitor or angiotensin receptor blocker is not recommended for the primary prevention of chronic kidney disease. In those patients, yes, they are diabetics, but without renal impairment, but without albuminuria, and with normal blood pressure. There is no rule for primary prevention by giving ACE or ARB for those patients. We cannot pass through the diabetic nephropathy without mentioning the targets. And I know that it is mentioned a lot in this meeting, but we have to reconfirm again here that we have the target of 130 because we have diabetes and we have chronic kidney disease. So we have the target systolic blood pressure of 130 as a proven benefit, but not below 120 as a proven harm. Again, here from the European Society of Hypertension and European Society of Cardiology, that several trials testing the use of combination of two RAS blockers, but of course, most of them has proven harm than benefit. That's why it came here as a class 3 for simultaneous administration of two RAS blockade, and ACE and ARB is not indicated and even harmful. Another important evidence here came from Canada that all people with diabetes and chronic kidney disease should receive a comprehensive, multifaceted approach to reduce the cardiovascular risk, because of course they have an extreme risk. So that's why we have to manage it in multifaceted approach. And also adults with diabetes and chronic kidney disease with either hypertension or albuminuria should receive an ACE inhibitor or an ARB to delay progression of chronic kidney disease. And here we have an evidence of level 1 or grade 1 ACE inhibitor used in both type 1 and type 2 diabetes. And there is a difference here between ACE and ARB, and that ARB, it can be used evidently in type 2 diabetes. But ACE inhibitor, both in type 1 and type 2 diabetes. A long time ago also, the ACE inhibitor is proven to be more renoprotective than conventional therapy in type 1 diabetes as regard the renal impairment status and significant as regard the significant reduction in proteinuria in the captopril versus the conventional therapy. Also, an important evidence came from the micro-HOPE. The micro-HOPE cardiovascular and renal outcome in the heart outcomes prevention and evaluation. And the aim of the micro-HOPE in a specific subsets of patients with diabetes of HOPE trial was investigated. The primary variables with the development of diabetic nephropathy in patients with microalbuminuria or the development of microalbuminuria in patients not presenting this condition at the baseline. Of course, the study design was randomized, double-blind, placebo-controlled, with a considerable number of diabetic patients, around 3,500 patients aged more than 55 years, including more than 1,000 with microalbuminuria. And of course, the follow-up period was from 1 month and then every 6 months, with important primary endpoint, which are the development of myocardial infarction, stroke, or cerebrovascular disease, and another important secondary endpoint, the total mortality, admission to hospital for congestive heart failure, unstable angina, cardiovascular revascularization, or the development of overt nephropathy. And if we have a look here to this graph, we can appreciate the significant reduction of overt nephropathy by 24%, which made an important evidence for ACE inhibitors from the HOPE trial, which is a micro-HOPE trial. From the study utilized Taiwan's medical and pharmacy claims data in the longitudinal cohort of diabetic patients, and this was 3 years ago. The comparative effectiveness of angiotensin converting enzyme inhibitor versus angiotensin II receptor blockers for major renal outcome in patients with diabetes, and you can imagine here that it is a 15-year cohort study which concluded in their analyses that similar effects of ACE inhibitor and ARBs in patients with diabetes. And we have to mention that around 34,000 patients received ACE inhibitor and about 23,000 patients received ARBs. However, the ACE inhibitor might provide additional non-protective effects among patients who have cardiovascular disease or chronic kidney disease. And of course, it cannot pass without mentioning this important recommendation from the American Diabetes Association few months ago. ACE inhibitor or ARBs are the preferred first-line agent for blood pressure treatment among patients with diabetes, renal impairment, and proteinuria. But what is more important is that in general, ACE inhibitor and ARBs are considered to have the similar benefits and risk, and this came from the latest recommendation of the American Diabetes Association. Finally, this is my last slide, and of course, as we are all in home, it will be in-home messages. And the first in-home message: diabetic nephropathy is an old but gold story with extreme cardiovascular and end-stage renal disease risk scenarios. Glycemic and the blood pressure control are playing major roles to break down this major problem. And of course, RAS blockade, ACE or ARB, but not in combination, is fully evidenced in prevention and treatment. And as I mentioned a long time ago, the ACE inhibitor has superiority in type 1 diabetes, diabetic nephropathy. And of course, no rule for primary prevention for those patients with diabetic nephropathy with normal eGFR, normal urinary albumin creatinine ratio, and blood pressure. And finally, when facing diabetic, we have to consider the diabetic nephropathy. We have to diagnose it well, and we have not to miss by dipstick the presence of microalbuminuria. We have to prevent and treat it properly by using the RAS blockade for better cardiovascular and renal outcome. And finally, I hope for you all to pass this tough day and to back to normal life safely so soon. And thank you.
I think it
actually I didn't receive any questions on the WhatsApp.
I think we can make a question at the end because already this is a debate, so it's better to have another opinion, and then after that we can discuss the opponents. So it's my honor to introduce Enrico to Rossi, a past president of the European Society of Hypertension. He's a contra, so I need Enrico. I know that you can make pro, you can make contra, so I need you a contra now, Enrico.
Okay, I want to put.
Thank
you very much.
I will do.
Share.
I will do. I do.
No. Okay. think it was very well organized, very successful. My presentation is related to this debate. Of course, as any debate, one is trying to emphasize the topic that has been assigned, and therefore this is my personal view, let's say, although it is shared by several colleagues, but it's my personal view, of course. We have heard beautifully how important is diabetic nephropathy. The alteration of renal function is due to several mechanisms, of course, starting with hyperglycemia, quite often associated to hypertension, particularly in patients with type 2 diabetes, and include the alteration of mesangial cells, vessel walls, interstitial cells, facilitated by stimulation of the renin-angiotensin system activity, tissue renin-angiotensin system activity, with stimulation of several growth factors, with production of collagen leading to glomerulosclerosis, but also by other factors, including advanced glycation end products that may favor the glomerulosclerosis, prorenin, and other growth factors. Well, all this alteration from a clinical point of view, as we have heard before by Professor Tsiufis, is demonstrated by the presence of microalbuminuria and reduction of glomerular filtration rate. And this is the natural history of the development of albuminuria, proteinuria, hypertension, and stage renal disease and cardiovascular disease in type 1 and type 2 diabetes mellitus. I will concentrate on type 2 diabetes mellitus because it has been shown that experience with angiotensin receptor blockers in type 1 diabetes mellitus is scarce or nothing at all. And in patients with type 2 diabetes mellitus, there is, of course, a high risk for cardiovascular disease when the microalbuminuria is present, which may happen also from the beginning of the history, together with hypertension that may be present in 30–40% of patients. Later on, after several years, hypertension is present in about 80% or even more of patients with type 2 diabetes mellitus. And at the end stage, renal disease may be developed. So in the natural history of diabetes and diabetic nephropathy, there are several stages, from the more advanced with very, very high risk, or with the beginning with mild increase of blood pressure with or without microalbuminuria, and then early diabetic nephropathy. Why I'm showing this simple concept? This is because when we talk about studies that have looked at the effect of RAS blockers, also meta-analysis that have looked at the comparison between ACE inhibitor and angiotensin receptor blockers, of course there is a lot of heterogeneity, and the studies performed differed each other in terms of type of patients that have been included, more or less severe nephropathy, those with predominant proteinuria, those with predominant reduction of glomerular filtration rate, and also treatment in terms of stage of initiation, duration of treatment, dosages of drugs, and so on. So we have to take into consideration all these variables, this heterogeneity, when we want to take the most important information from these studies. And we have also to consider that reducing blood pressure per se is effective in preserving the renal function, at least in reducing the progressive decline in kidney function. So even the decrease of blood pressure in these patients is important in order to give a good interpretation of the results. But drugs may be different in the effect on renal function for the same changes of blood pressure. You can see here in the IDNT trial, in which in patients with diabetic nephropathy and proteinuria and angiotensin receptor blockers were compared to placebo and with a calcium antagonist, that for the same blood pressure achieved during treatment, there was a better renal preservation of the renal function with the angiotensin receptor blockers in comparison with placebo or amlodipine. Obviously, as I said, most of these patients have hypertension, and meta-analysis on antihypertensive drugs in patients with or without diabetes mellitus have been performed several times. This is one of the most recent, very careful meta-analysis by Alberto Zanchetti and co-workers, including 41 randomized clinical trials in patients with diabetes, including more than 60,000 patients, versus 40 randomized clinical trials in patients without diabetes and 190,000 patients. So the conclusion was, when compared to other classes, RAS blockers were equally effective in cardiovascular prevention in no diabetes, but moderately so significantly more effective in diabetes mellitus. So justified use of this drug in patients with diabetes. RAS blockers, and particularly angiotensin receptor blockers, when compared with placebo, are markedly effective in reducing risk of end-stage renal disease in patients with diabetes, although information on other drug classes is practically absent or very, very modest. So there is agreement that RAS blockers should be used in patients with diabetes. Another observation that we know is that reducing proteinuria is effective in protecting the kidney and in preventing cardiovascular diseases. This is a slide taken from the results of the on-target TRANSCEND study, and demonstrated that changes in albumin excretion during treatment could predict the cardiovascular and renal outcome. In particular, the reduction by 50% improved all these endpoints: cardiovascular death, composite cardiovascular endpoint, and renal endpoint, while increased by 100% increased these endpoints. So changes in microalbuminuria, of course, which is quite effectively affected by RAS blockers, is important in terms of renal and cardiovascular protection. So that also the prevention of microalbuminuria by angiotensin receptor blockers such as olmesartan is really a good news. And as we have seen before, in people with diabetes, treatment strategies consist in reduction of blood pressure up to 130 millimeters of mercury, although in older people the target may be a bit higher, but particularly treatment should be initiated with RAS blockers drugs in combination with calcium antagonists and diuretics. As we have heard, combination of ACE inhibitor and angiotensin receptor blocker is not indicated. And in patients with chronic kidney disease in general, again, it is emphasized that RAS blockers are more effective at reducing albuminuria than other antihypertensive agents, and these are recommended as part of the treatment strategies in hypertensive patients, particularly in the presence of microalbuminuria and albuminuria. So, in studies that have tried to compare the effect of ACE inhibitors or angiotensin receptor blockers versus placebo, or even directly ACE inhibitors versus angiotensin receptor blockers, which are the results? This is, again, a recent meta-analysis on 50 randomized clinical trials, including almost 250,000 patients, and you can see that for several outcomes, there was no significant difference between ACE inhibitors and angiotensin receptor blockers. If we look at other meta-analyses, patients with diabetes and with more or less severe impairment of renal function, we may have some interesting results. For instance, in this meta-analysis on the effect of ACE inhibitors versus angiotensin receptor blockers on proteinuria, albuminuria, meta-analysis of 17 randomized controlled trials, including almost 18,000 patients, ACE inhibitors and ARBs can reduce urine protein levels, improve blood pressure, and were similarly effective in terms of reducing urinary protein excretion. This is a registry on reduction of atherosclerosis. So in patients at high cardiovascular risk with many risk factors or who had already suffered a clinical event. And this observational study after 4 years concluded that ARB use appears to be associated with 10% lower rates of cardiovascular events compared with ACE inhibitors. But this was an observational study. This is another meta-analysis, including more than 100,000 patients in adults with diabetes. Comparison of different RAS blockers showed similar effects of ACE inhibitors and angiotensin receptor blockers on major cardiovascular and renal outcomes. So this meta-analysis demonstrates a similarity, the effect of this drug. And this is another very large meta-analysis by Franz Messerli and his collaborators. They included more than 250 patients from randomized trials. More than 100 randomized trials were considered, and sensitivity analysis that were restricted to trials published after 2000 revealed similar outcomes with ACE inhibitors versus placebo and ARBs versus placebo. Head-to-head comparison trials of these two classes of drugs exhibited no difference in outcomes except for a lower risk of drug withdrawal due to adverse effects with angiotensin receptor blockers. Why this meta-analysis included trials published after 2000? This is because other meta-analyses demonstrated that in comparison with placebo, ACE inhibitors were able of reducing total mortality, cardiovascular mortality, myocardial infarction, but not angiotensin receptor blockers. From this observation, that were not head-to-head comparison, but results of studies versus placebo. From this observation, some stated that ACE inhibitors were more powerful in preventing events in comparison with angiotensin receptor blockers. But this is the consequence of what is called the generation gap. This is because ACE inhibitors were introduced in treatment in first ACE inhibitors was captopril introduced in 1981, and they were studied particularly in the 90s. Angiotensin receptor blockers came later. Losartan, the first, was introduced in treatment in 1995. And trials performed before with ACE inhibitors had more placebo event rates. Most of the patients were naive to RAS blockade, and there was rarely an aggressive control of risk factors. On the contrary, trials with angiotensin receptor blockers had more frequently an aggressive risk factor control, for instance, with aspirin or with statins, and more rarely the patients were naive to RAS blockade. For instance, in the HOPE study, less than 30% of patients were on statin, while in the on-target, the majority of patients, more than 60%, were on statins. So it is difficult to have a so clear reduction in events in the ARPS trials who came later. On the contrary, angiotensin receptor blockers were found effective in several clinical conditions: hypertension, left ventricular hypertrophy, hypertension with cardiovascular risk, congestive heart failure, and also with diabetic nephropathy. And in addition, in patients at high cardiovascular risk, where there was a direct comparison with ramipril in the on-target study. So what is important is certainly the direct comparison, the head-to-head comparison. What I said before on the difference of trials performed early with ACE inhibitors is depicted in this slide. For instance, patients included in the HOPE study in the placebo arm had almost 18% of events. Given ramipril, there was a clear reduction in events to 14%. This number of events in the arm treated with ramipril was almost similar to the placebo arm of the TRANSCEND study, in which the drug given was the angiotensin receptor blocker telmisartan. So there was a clear difference in the number of events in the patient in the placebo group. This means that the population studied in this HOPE trial was more sick, had greater risk for cardiovascular disease. And in this trial, the patients were at lower risk. This may be the difference in the incidence of cardiovascular events. In fact, when we look at the head-to-head studies, such as in this meta-analysis by Messerly and collaborators, you can see that cardiovascular mortality, myocardial infarction, stroke, and stage renal disease were almost similar. In any way, no statistically significant difference. But if we look at drug withdrawal because of side effects, then the withdrawal was much less in those with angiotensin receptor blockers. Okay, and only trials in trials that compared the active treatment versus placebo only with angiotensin receptor blockers, there was an improvement with in terms of drug withdrawal. And this meta-analysis is probably difficult to read, but you can see that the reduction of cardiovascular events by all classes of blood pressure lowering drugs is accompanied by increased treatment discontinuation for adverse events, except for angiotensin receptor blockers. Treatment discontinuation was significantly less only with angiotensin receptor blockers as compared to the other classes of antihypertensive drugs. And this is what happened in the on-target trials. The risk of discontinuation was much greater with ramipril than with telmisartan. So to conclude, ACE inhibitors and angiotensin receptor blockers are first-line drugs in hypertension and its compelling indications, including non-diabetic or diabetic nephropathy. Randomized clinical trials and their meta-analysis on ACE inhibitors and on angiotensin receptor blockers indicate that efficacy is similar or may even be better for ARBs in some studies. So in any case, given at least equal outcome efficacy but fewer adverse events with ARBs, risk-benefit analysis indicates that so far ARBs should be preferred as initial treatment in diabetic nephropathy. Thank you for your attention.
Yeah, Dr. Sobhi, I have 3 questions. Okay. Okay, thank you, Professor Dr. Said Farag and Dr. Enrico, for this very comprehensive and very good lectures. I have 3 questions, one for Dr. Said Farag and the other 2 questions for Enrico. First, for Enrico, we have 2 questions. When we expect the improvement in the albuminuria after starting the RAS, either ACE or ARB? When we expect that we have a reduction in this albuminuria? The other question is how to follow up the improvement when the patient is on ARBs, or when we add ARB to a patient with diabetic nephropathy. First, when to expect the improvement and how to follow up. First, we start with Dr. Enrique, and then we will give the question for Dr. Said Farag.
Okay. The effect of RAS blockers, particularly with angiotensin receptor blockers, on albuminuria, proteinuria, appears quite early in terms of weeks. Of course, particularly for the lower concentration of albumin excretion rate, it is needed to repeat at least 2-3 times the measurement in order to have a baseline values. But the effect appears quite early. But this is only one of the markers of renal function, because if we look to changes or rate of decline, less decline in glomerular filtration rate, of course, this takes a quite long time. In these trials, we have to differentiate the effect on protein excretion and the effect on glomerular filtration rate. Usually, in most of this trial, the renal endpoint was a combination of end-stage renal disease, doubling of creatinine, and dialysis. Of course, all these endpoints take a long time, months, if not years, to be observed in these patients. Other studies look at only changes in proteinuria, and this, of course, may be observed in a few weeks or few months. So we have to differentiate this different approach to look at endpoints for renal function.
Okay, thank you, Professor Enrique. And then we have a question for Dr. Said Farag. As regards the use of ACE in the diabetic nephropathy, there is any privilege of an ACE over another? And when we are starting with an ACE, do you prefer to start with a small dose and then we will see the response? Or we will start with the highest dose, as we know that these high doses that cause the renal protection. So you suggest to start with a smaller dose and see the effect first, or we start with the high dose from the start?
Okay, it is. Thank you, Professor Amin. It is actually a very good question. Of course, if we would like to mention one ACE preference over another, we will back to the evidence, and the evidence here came from the HOPE and MicroHOPE trial. This is the biggest evidence, especially the MicroHOPE, who used the ramipril in a maximum dose, of course, 10 milligram. This, I think, gave a privilege to ramipril over the other ACEs for the treatment and prevention of diabetic nephropathy. But it goes without saying that the guidelines is generalizing the concept of ACE inhibitor. As regard your second question, which is the dose we will start with, also this is a good question. As you mentioned, the benefit came from the maximum dose of ACE inhibitor. It's true. If we are initiating the ACE inhibitor in a patient who is naive for ACE inhibitor, we have to respect the problem of first dose hypotension, and we have to start with the low dose, and we will go up, titrating up the dose once we are confirming that there is no developing of side effects, especially the hypertension. But if the patient is already on ACE inhibitor, we have to maximize the dose once we prove that the patient has diabetic nephropathy and proteinuria.
I have a question to both of you. We all agree about this debate that there is no difference between ACE-ARBs, but particularly ARBs is protective better according to the meta-analysis. But is any drug the same? I mean, every ARB the same drug, or every ACE the same, or depending on the trial? Because some drugs have trials, some not have trials. The second, that some have dual pathway and one has a single pathway. So do you think that according to which, for example, ARBs, you have navigator trials, you have renal trials, you have roadmap trial, but you don't. You have for those patients taking, for example, this approval. We have two trials for the IDNT trial. So I can't see which drug I prefer, because sometimes I prefer this drug have a protection for cardiovascular. For example, for post-myocardial infarction, you have only one drug, which is according to the Valiant trial, and you have the ACE two drugs. But I don't have for this renal protections or diabetic nephropathy a single drug that you say this is the drug.
You are right. Thank you for this question. It's difficult to answer. We may give just an opinion, because in fact, several angiotensin receptor blockers have been used. We may add to those who have quoted telmisartan, of course, that has been evaluated on target in comparison with ramipril. This is a very important study, of course. The telmisartan has been evaluating the detailed study in comparison with enalapril. Olmesartan has demonstrated to be effective in the prevention of microalbuminuria. So all these drugs possibly can be used. Irbesartan in the study in comparison with amlodipine. So the choice may be the drug that has been used in patients more similar to the patient you have seen, but at the end, all these patients overlap, the characteristics of the patients overlap each other apart from the prevention, but all overlap each other. So I think that the choice is a very personal choice with the drug for which one is more familiar and not other difference. At the end, the results should be the same.
Adding to the question of Dr. Amin about the dose, we see that in protection, usually we have a high dose. But for this CKD or patients with diabetic nephropathy, you are afraid of a high dose, which can produce complication to the GER. So this is the contradictory about the high dose effect and the high dose side effects. So how can you manage?
Well, certainly angiotensin receptor blockers are very well tolerated. So even increasing the dose, the tolerability is usually quite good. But at the end, if we look at results of clinical trials, we have to use as a maximum doses those that have been used in the trials. There is no reason to increase the dose in addition to the effect that has been demonstrated.
I mean, yeah.
Actually, this is a question that we have, but can we summarize that that in a diabetic patient with type 1 diabetes, ACE might have more evidence and more trials, and in type 2 diabetes, they share the same results and they have many trials. And I think if the patient has also a cardiovascular disease in addition to this diabetic nephropathy, which is not uncommon, I think ACE will have an edge here. So you share me with this or not?
The largest study that has compared an ACE inhibitor and an angiotensin receptor blockers is the OnTarget, almost 17,000 patients. And these were all patients at a very high risk. So I think that well, we may speculate what we want, but at the end, if we have to trust the results of large trials, we have to accept what came. And I agree that in the OnTarget, not all patients were diabetics or had diabetic nephropathy. If we are concentrated on this topic in some way, you may be right. But what is most important in conclusion from randomized clinical trials in comparison of drugs is the head-to-head comparison. And the largest trial was a trial in patients with very high risk, and there was no difference.
Okay. I think we can finish now. Thank you very much, Dr. Syed, Dr. Enrico, and Dr. Amin. And it's a chance now because Enrico will not join us to Ancosta tomorrow. So thank you very, very much for attending this conference, the first virtual conference in my life to have hypertension. It's a chance to have this interview and this virtual and this technicalities, and to see you and in your office and see me in my office or my home, or and also to gain the confidence that we are giving confidence to each other in order to overcome this disastrous nightmare. I think we will finish as soon as possible because of this smile of Enrico. I see the smile of Enrico now in front of the screen, because Enrico have the highest mortality, but he's smiling. I think Italy will overcome as soon as possible, and all the other countries. And I hope to stay home, stay safe till the end of this disastrous plan. Thank you very much, Enrico. Thank you very much, Costa. And on behalf of myself and CVREP, give you to have a nice weekend in your home or around your home. Thank you.
Okay, thank you very much. It's been a pleasure. We succeed.
Okay.
We succeed.
Bye-bye.
Bye-bye.